Record, huh? Very good. Levin sign, huh? See, this is what? Levin sign. Pain.
Good evening to all of you. It's a pleasure and honor to welcome you all once again on day 3 of this virtual conference in collaboration with APCI. Today, the theme is acute MI interventions. Last couple of days, we had interventions in calcific coronaries as well as in bifurcations. And today, we are going to have discussion primarily on acute MI interventions. And today we have two cases in the box, which taking approximately around 45 minutes each, and then the lectures. And with this short introduction, let me introduce the expert panel. Today we have with us Dr. Balaji from Madras Medical Mission, Dr. Rafai Shaukat Ali from Apollo Hospitals, Chennai. Then we have Dr. Kalai Chelvan, who is the senior interventional cardiologist at Madras Medical Mission, Dr. Joby K. Thomas from Caritas Hospital, and senior interventional cardiologist, the head of the department of Aster Medicity, Dr. Anil Kumar. And along with the experts, we have the moderators, Professor Giuseppe from Italy, Professor Elvin Kedi from Belgium, and Dr. Jay Gopal, who is the MD of Lakshmi Hospitals at Palakkad. We'll go ahead with the case in the box, and Dr. Shiv Kumar is presenting the case in the box from Madurai Meenakshi Medical Mission Hospital. Jay Gopal sir, kindly take over.
Yeah, thank you, Dr. Deepak. Good evening to all of you. I think we'll not waste too much time. I'm really honored to be here, part of this virtual conference. I think we have about 45 minutes for the live in the box. And Shiva, are you ready with your presentation?
Yeah, I am ready. It will be served from the server. Okay. So whenever you want to pause, you can have a full control. Whoever give the instruction, the server can stop it and they can play back.
Yeah, I think so. We have a really excellent session here, because I think this is what really attracts most of the interventional cardiologists, particularly the youngsters. Acute myocardial infarction, which has become the primary PCA, has become the order of the day in most of India. I think without much ado, I think we'll go straight away to your presentation, Dr. Shiva.
Yes, sir. So, Anand, can you just, yeah.
For more than 30 years, Meenakshi Mission Hospital, Madurai, has been the backbone of the health of South Tamil Nadu. With 45 departments and 1,000 plus beds, it is the numero uno multi-speciality hospital in the temple city of Madurai. Bringing world-class medical facility to the common man's doorstep is our motto. One such fine example is our cardiology department. Meenakshi Mission Hospital is the first hospital in South Tamil Nadu with 3 fixed cath lab and an electrophysiology laboratory with 3D navigation technology. It is equipped with the state-of-the-art intravascular ultrasound integration and optical coherence tomography. With this, we can proudly say our heart is big, our heart is young, and our heart is strong.
I think we are getting the case in now. I really appreciate Dr. Deepak for asking me to do a primary PCI. I thought, why not live? You're putting a lot of money and effort and hard work. He said, I want to make sure you know that acute MI doesn't fall in right time groups.
This is what? Levin sign.
So then fine. The lady came with the fist in chest. This was some around midnight. Very agonizing pain.
This is radial.
With the permission of Dr. Jay Gopal, shall we pause here, sir? Dr. Jay Gopal?
Thank you. I think I'll also request my the co-moderators for the session, Dr. Kedi and also Dr. Giuseppe, to join actually in the discussion. Yeah.
Can we just pause a minute and discuss?
Yeah, I think today the concern of doing a primary angioplasty has really disappeared. I think it's become an accepted modality of treatment, and I think more so the radial route has become the preferred option. So I just want to get to your, I think at least in our part of the country, southern part, I'm fairly certain also the remaining part of the country, it should be close to about 95% radial this thing for acute MI. What about Belgium and the rest of the
Yeah.
Italy? Yeah, we would like to have your viewpoint also.
Well, I leave first Giuseppe. He has much knowledge on this, not only for Italy, but also for the rest of Europe. He has done a lot of publications on this field.
Thank you, Alvin. Now, at least in my cat lab, but in Italy, in Europe, it's more than 90% of cases. Of course, we still use a femoral approach for hemodynamically unstable patients when we believe that we should put some mechanical support device. Otherwise, we go in almost all the cases through the radial. I personally prefer the left radial approach. I do routinely left radial because it's my opinion. It's much better than the right one. This is my personal experience. So.
That's fantastic. I think in acute MI at least, there are a lot of anticoagulants, antiplatelets, sometimes bailout tyrofibon on board. I think definitely radial, we feel. I think this is one area where there is definitely
absolutely. Now guidelines, they recommend as class 1, they recommend radial as class 1 in acute myocardial infarction. So should be the preferred route, the preferred access. Absolutely.
Right. Perfect. If there is no much debate on this against femoral, we can move on. Anand, can you just play?
Dr. Giuseppe, in very obese patients, we find it difficult to go across the belly to have a left radial procedure done. So in extremely obese patients, would you also prefer going through the distal radial near the anatomical snuff box, or would you still consider the regular radial site?
The question is whether you go for the distal radial. Yeah. So anatomy near the anatomical.
We got the radial puncture. We are proceeding for angiogram.
Any specific reason why the left over the right?
Female presented to us with acute chest pain. Initially to an hospital elsewhere with the central chest pain radiating to the shoulder with diaphoresis. Considered local hospital, diagnosed only inferior wall and was given low dose of aspirin and clopidogrel. Then when she came down here, it was 6 o'clock, she came down here by 11 o'clock. She had ST elevation in inferior leads and her receiving BP was 120. She had a transient episode of Brady AV dissociation and there was drop in systolic BP to 80, for which she started on IV fluids and was given IV heparin 5000. Then the auscultation showed no murmur, the lungs were clear. She was shifted to a CT room where the COVID was ruled out and she was brought to the cath for an emergency angiogram followed by a primary PCI.
Can we just
EKG where you can see
Can you pause?
Can we pause?
Anand?
Yeah.
Anand, can you pause it?
Can you pause it for a second? The question why, because all of us know COVID times has been extremely difficult in terms of getting the patient to the lab. So what's been the consensus? Do you take every patient for a CT before you take them to the cath lab?
Yeah.
No, but I
Yes,
don't know the consensus of opinion on that, because most of us, in fact, I've never denied a primary angioplasty for any of the patient. In fact, 3 of them turned out to be COVID positive later on. But then the protocol is that we would do an antigen, wait for about 20 minutes, by then the patient would leave, and then we'd go ahead and take all precautions as if it were COVID positive and finish off.
The very idea of ruling out COVID was not to deny a primary PCI, just to know are we dealing with a suspected case, negative case, or a strong case of COVID, so that we can gear up your level of protection 1 to 2 to 3. If it is a confirmed case of COVID, your level of protection has to be 3, and you have to put the case in the dedicated COVID lab. And once the case is done, you need to sterilize the lab. So need to have that idea, where to do, how to do. In that context only it was done.
Your point is well taken. Can we have opinion of the House, Dr. And Dr. Eldin, what is the protocol in your place?
Well, we are moving out of the COVID phase now, but when we were in that situation, we had a dedicated cath lab that was only for the acute COVID or not COVID cases, and we all will be dressed as assuming that it's COVID just in case. it was, and we would not delay primary PCIs. We'll just accept them. We had a separate cath lab just for that. We had reduced the number of stable, or let's say elective procedures at that moment, which were going on in the other cath labs. And we had a dedicated team, and they went in dressed, assuming that the patient had COVID, and continued with the primary PCI. Patient then was put on isolation, but after the treatment.
Yeah, I think just to catch up, I mean, Dr. Anil's question was not answered a little earlier. Is there any specific preference for the left radial? In fact, Professor Gisep was, you already hear the viewpoint, and we are, as mentioned by Deepak, it's extremely difficult for when you have an obese patient to go over the belly and to really do the procedures. We find a little cumbersome from the left radial.
And most of us are doing right radial, even in acute MI.
Well, I'm also doing mostly personally right radial, although for me, I don't have a problem to climb over and have long hands, but I think that the most of people who prefer the left radial is that sometimes when you go right, you have a loop around the esophagus, and that makes it difficult. While if you go from the left side, it's still there, but less eccentric, and you could still do and not lose time during the primary PCI.
Thank you. Shiva, can we go ahead? I think
Yeah, please. Anand, please go ahead.
Outside ECG also, it's seen the ECG which done in our AE shows the ST elevation in lead 3 is more than lead 2. The ST depression 1 AVL, V1, V2, V3, V4. So it's all the clinical syndrome, the Brady, AV dissociation, Venki back grouping of beats, ST elevation more than 3 than 2 with the ST depression in chest leads tells probably the occlusion is proximal RCA. And with this, we did an echo. Echo showed wall motion abnormality involving inferior wall and posterior wall with the trivial MR and no PE. And we looked at the IVC. IVC was normal in size and collapsible. With this, we proceeded with an angiogram. The angiogram, it looks like it was a radial approach. Looks like an anomalous takeoff of the RCA. As we predicted from the history and from the EKG, it was suggesting to proximal RCA total occlusion. Can you play the next one? This is left. There is a critical stenosis involving the ostium of the LCX. Left main looks okay. Next shot. There is another high-grade ulcerated plaque sitting at the proximal LAD2. So basically, triple vessel disease, STEMI, inferior wall, total RCA. We are interested to fix the RCA today. Probably in this index admission, we will be fixing the other two at a later point. 12:30, we received the patient somewhere around 12, and we wheeled her to our lab. And within half an hour, with CT everything, we could get her, and the angiogram was done. So we received her somewhere around 11 p.m. at our AE with all the logistics, ruling out the COVID, discussing with the family. It took 1 hour, and we are somewhere around 12 o'clock, midnight past, and we are proceeding for a primary PCI.
It was really anomalous. RCA was giving a trouble. The patient was a bit stable, labored breathing. Initially, wire went into a tiny branch.
So initially, the wire was in a different vessel. That's how it is in acute MI. We cannot perfect at the beginning. So looks like there is a mid RCA tight lesion and proximal RCA some thrombus. We'll do once again one more thrombus section. We are planning to give some intracoronary nicorandil. Without nitrate, as BP is on the lower side. So, can you guys show the angio one now? We'll have one angio now.
This was
BP is still on the lower side. I'm worried, but patient is on fluid and inotropes. This is after the second thrombus aspiration. You can see the beauty of now. The entire RCA has come up. Patient is quiet. ECG is settling down except for the BP.
Anand, can you freeze here? Dr. Jayagopal, with your permission, can we discuss routine thrombus aspiration versus selective?
Yeah, I think we have brought in a very important point. So, How frequently do you do thrombus aspiration in your lab these days? We have all of us agree that particularly the COVID times, we've seen extensive thrombus. In fact, the other day I had a guy who had an extensive thrombus even in the left main. So how frequently do we do thrombus aspiration going by the present day literature? Let's hear from the experts also, my colleagues as well. I mean, my use is very limited. In fact, maybe though I do about 25, 30 primaries in a month. So maybe once in a month is my usage of I don't deny that it gives results in some of these patients, but it's come down drastically. Well, I mean, I would like to hear the opinion from the others as well.
I think we have young guns here, Kalai, Balaji, and Rafai too. These guys also do a lot of acute MI. Your take on thrombus aspiration routine versus selective.
So we've been doing primaries for many years, and we know from the first data which came from TAPAS suggested that routine thrombus aspiration improves outcome. And there's a single center study from Canada, I think. And we are all doing routinely for all primaries, wire and thrombus aspiration routinely. But then we had the TASTE and the TOTAL, 2 trials, nice trials, which clearly shows that you're doing a thrombus aspiration, actually not much benefit, but you may actually harm the patient by giving a stroke. So that doesn't mean that you should not use it. It's only for routine aspiration in primary PCI. So what I do in my practice, as we said, probably around 10%. When I pass the wire, if I have a TIMI-3 flow, I would not use thrombus aspiration. Even if it's no TIMI-3 flow, I will use a gentle balloon inflation to see if there is good flow. Only if there is a thrombus grade of anything above 4 and 5, I would get my thrombus catheter. But every cath lab should have a thrombus aspiration catheter on shelf, particularly the bigger lumen ones. So you know that there are different types of thrombus aspiration catheters like Export, and Terumo has got one. But if you have a very high-grade thrombus, you actually need to use bigger lumen ones like Hunter, which aspirates more thrombus than the smaller ones. So I would rather go for a bigger aspiration catheters in those high-grade thrombotic lesions in very selected group of patients in primary PCI. But yeah, routine thrombus aspiration is not my take anymore. But I think I would probably say around 10% of my cases we use thrombus aspiration.
Yeah, that's great.
Yeah, I think I agree. Also in ectatic coronaries. Dr. Anil, yes? Also in ectatic coronaries, yeah, you have huge thrombus load, and
especially in the acute MI COVID scenario, we are having huge thrombus load, and you balloon and balloon, it will become worse. So definitely this, as Dr. Rafai has pointed out, when the thrombus burden is higher, you should be using it in and individualize it rather than just make it as routine. I think that's what we are all doing now.
I think that one of the issues I have is many of the cath labs doesn't even have thrombus aspiration catheter. They think that it's all out of interventional cardiology. And I think that's a sad state. We should, every cath lab should have thrombus aspiration catheter ready to use it when we need it.
I agree, perfectly agree with you. I think that's a message which should go down the meeting. So
I think the message is well conveyed. Shall we play it? Anand, play the image.
It's a kind of lesion involving. Is the final shot which we took now? Right. Freeze it. I think there is a lesion involving mid-RCA. There is that haziness which I thought the thrombus again looks like a lesion there. So whole lot I think I have to put a stent anywhere from the mid-RCA to the proximal. And before that I want to have a look at the. Now we felt the thrombus, we gave a couple of runs. Then after the run, the angio, we thought it's all lesion now. There is another lesion in the distally. See one injection distally. Let's see what.
Anand, can you freeze it here? How often you do when you see a doubtful lesion in the distally? How often you do selective distal injection? Not in all cases of doubtful lesion. When you don't see the distality. Sometimes if you just cross the lesion beyond the thrombus, all the lesions out, you will get the distal vessel. So you need not wasting time on repeated aspiration and balloon. Once you get the distal anatomy, you can go ahead with planning the proximal. How often you guys do this distal selective injection? I don't do routinely. Sometimes when I see a lesion distally, if I have to figure out, I do this. Can you just play that image? Then we'll discuss.
I think not bad. There is one distal lesion which will balloon out. So we thought of doing an angiogram, so doing an imaging, but considering the distal flow. Yeah. So after the distal dilatation and aspiration, we lost the RCA again. So we wired anomalous, patient was uncooperative, so a lot of test. So we are now ballooning the mid again. Okay, balloon panna. Dilate panna. Then 2018. Eduthu. Dilate. 2018. Eduthu.
Anand, can we freeze here?
Test kodu.
Yeah, I think Deepak Davison is also here, and Dr. Jay Gopal and all the moderators, experts here. See, I did a thrombus aspiration, I did a ballooning, but I lost the vessel back. Do you think after that one first aspiration without ballooning, I could have gone for a direct stenting? Is anybody voting for that?
I think Shiva, I would try to limit the number of balloon dilatations, and once the wire is gone and you're seeing the distal vessels, and if you're not seeing much of a thrombus, I would not even try to have too much of runs of the export or whatever your thrombectomy. I mean, definitely, if it's an elderly lady, I would like to open up because the lesion in the mid segment looked a little tighter. So I would have tried.
Right.
Next would have been to dilate that, and then probably would have stented the culprit. Finally, you have to get the flow in. So the culprit looked like the mid and the proximal and the mid lesion. I would have covered with one stent and finished off. Distal, I mean, it's debatable whether you would like to just ballooning that and leaving it like that doesn't make sense. There's a good flow down there. That's my take on this.
Yeah, that's the same reason I also did a pre-dilatation. It was a 66-year-old female. The mid lesion was looking critical to me. I want to have the feel of the artery, maybe some calcium. I may end up in under expansion. So mid RCA is known for nodule and calcium because of the torsion phenomena. And we all know that 10% of the acute MI happens because of the calcific nodule. So, but I felt once the artery closed after pre-dilatation, I felt I should have gone for a direct stenting. So I think I was going by my presumptions, but I think if somebody would have done a direct stenting also, you would have finished the procedure earlier, and you would have had in between lost the branch. Dr. Anil and Dr. Kethi and Dr. from Italy, Dicosa. Please just direct stenting versus preparation like an stable PCI, in a routine PCI. Dr. Kalai and Balaji too.
If I may speak, I personally don't like to do balloon dilatation if I think that the stent will pass. Most of the time, you will have a dislodgement of the thrombus even more and some embolization of the thrombus. So only in some situations where you think that the stent will have problems to pass, then I will do a pre-dilatation. Now, another point that I want to touch on this case here is that distal lesion, which looks pretty tight. Now, the question is, would you tackle that or would you leave that as it is? Of course, it's clearly not the culprit. The culprit is the first two lesions you see, the proximal and the mid RCA. But on a long term, having that severe stenosis, having thrombus that will have the mashed potato effect after you've put the stent on those lesions, you'll have a lot of thrombogenicity, and the flow on that coronary artery will be limited if you don't open the distal lesion. So in my cath lab, I would treat the whole RCA, create the most optimal flow, and put the patient on double aggregants for at least 3 months, and then see in this age, because it's, I guess, also high bleeding risk patient.
I would agree. I would think that you would go ahead with the direct stenting whenever possible, reducing the thrombus propagation even lesser. And what about GP2B3A? The evidence is coming less and less. And such thrombus burden is there, you might even use that in such acute MI situations. What's your use, Dr. Kethi?
Well, especially if there is a lot of thrombus burden, I would use it. Otherwise, I'll stay off it. And if the TIMI flow after is good, then most of the time it's quite fine. Sometimes when I don't have a restabilization of the flow after the first ballooning, then I would also evaluate, and there is a lot of thrombus, then I would evaluate to put the patient on 2B3As while it stays in the hospital and take it the day after. There is some evidence of it, but we never really knew if it is strong evidence. It's a bit of a gut feeling that you have in some patients.
Anil, I think
Can we?
I am using
Can
a lot of intracoronary lytics also in addition in primary, and that works very well. In fact, when you have a huge thrombus, you could see the result right in front of your eyes. In
One third of the dose.
Yeah, it's one fifth of the calculated dose which you give intracoronary, and that really, in fact, particularly the RC and all that huge vessels, it just opens up pretty fast, and you get a TIMI-3 flow.
Right.
So,
what is the role of small size balloon with the minimum dilatation? Because it's a 60-year-old lady with the tight lesion in the mid RCA. Direct stenting, sometimes it is the stent is not yielding, then problem will start. I think
that was a question here. If you anticipate a bit of a calcium, and if you think it's a fibrotic thing which has to be open, then of course you need a balloon dilatation. You can't go with high pressure on a long stent and then have compromised the edges. So I think it's important that if you're thinking that this has to be opened up, but it all depends on what the anatomy is and the age of the patient. Young patient, no doubt, I think I would do a direct stenting and be done with it. Yeah.
Yeah, one another thing is that use of that export or the thrombus aspiration catheter. After balloon dilatation, probably if you see a no flow, probably you can use the same aspiration catheter to give intracoronary, even nicorandil or for that matter nitroprusside. Probably the effectively much more better than giving it through the guide catheter. Probably you can use that thrombus aspiration catheter up till the thing rather than dilating it again and again, causing more distal embolization. After first dilatation, if there is a TIMI 0 to 1 flow from whatever it was before, the gain we have got from the initial aspiration, we got lost after the balloon dilatation. Probably we'll have to get the flow on, then only probably we'll have to go ahead with the further dilatation. Otherwise, the myocardial suppression, with the pressures will come down, the vicious cycle of distal embolization and the hypotension, hemodynamic collapse will happen. So probably I would definitely, consider using a thrombus aspiration catheter, using a thrombus aspiration and give intracoronary whatever nicorandil or nitroprusside at this point of time.
Thank you, Dr. Balaji. Can we move ahead with the case? Can we go on? I think we're running short of time.
Sir, Dr. Giuseppe wanted to make a point.
So the
No, just
better now.
I
So we are,
personally,
we
when
are
there is a diffuse disease, first, if there is a thrombus, I do many. I think I go when there is a diffuse disease with a gentle predilatation, just to have the feel and to see how is the artery after nitroglycerin, because often you have vasospasms. So I like rebuilding the artery just with a small predilatation, gentle, not aggressive, but just to have the feeling, especially when there is some calcium. I use predilatation. So if there is a short lesion, I go with direct standing. If there is a diffuse disease, I prefer predilatation.
Thank you.
we had a plan of doing OSCT, but in view of very uncooperative patient with the flow coming and going. So we'll have one angio now. This is after multiple aspirations and ballooning. This is the RCA which she came with acute MI, and we have a distal POBA. We accepted the result, whatever there. There was a mid RCA tight lesion. There was a lesion in the proximal RCA2 with the thrombus, all sucked, dilated, and we are taking a. What's the diameter? We are taking a 348 stent. In case if it is not covering, I am have to put an additional stent.
Shiva, being a high volume imaging center, would you like to do imaging in these sort of acute MI sick patients? Or would you open up the vessel once the patient is stable? Still, would you want to do an imaging?
I think I have to put in one more stent there.
I'm already regretting for not taking a direct stenting.
Okay, take a scene.
Cell which is coming and going with the thrombus low. Distally there is a lesion.
Okay, deploy.
I think.
So we had put a one 3.5 into 70, 48, which has
we
covered
don't
the
purchase by doing an imaging.
proximal, but still left out
size.
in the proximal.
Maybe the stent maybe grow by a few 0.25 to 0.5.
So we have deployed a
I think my
3.348,
is very poor.
and now it is
So
post dilatation to the.
There was an interest for imaging,
stent.
but
9, 10, 11, 12, 13, 14, 16, 17, 18. எடுத்துட்டு ஒழுங்கா போ. டெஸ்ட் கொடு. ஓகே, கோ. எழுது. Go. எழுது. Go. எழுது. Go. 3.5 தானே?
Can we hear from the expert panel regarding the pressures for post dilatation? Because many a times we do see when you do aggressive post dilatation, you end up having a slow flow, extreme slow flow. So, what is your take on this? Would you routinely post dilate, or you deploy the stent at high pressures and stop it with that? And if you were to post dilate it, at what atmospheres would you do that?
Okay, dilate பண்ணு.
Well, in acute MI, that's a good question, Deepak. I think when you have a long stent,
This is the
definitely
additional stent for the
there'll
proximal
be some
left
areas.
lesion. This is now 3, 3 into 18, 3
Anand, can
18
you pause
overlapping
it?
with the earlier
Anand, can you
stent.
pause? Jayagopal sir, please go ahead.
Yeah. So I think my philosophy is, I mean, I look at the vessel size and more so on the RCA. Sometimes, you know, it's a little undersized. And so I would definitely, I mean, I try to limit the number of dilatations by taking a longer NC balloon, the non-compliant balloon, as far as possible. For example, you have a 48. So I would try to open up, but then I would not go to very extreme high pressures like 18, 20 or 22 until unless the lesion is not giving way. So I mean, I am really cautious about that. As you rightly said, after a long stand, you know, you finally end up in a slow flow or no flows at times. So I think it's also, that is the reason why, you know, in an elderly patient, you need to have a feel of the lesion. Sometimes, you know, you might think that you can do a direct stenting, but then if it doesn't open up, so the pre-dilatation, just checking it up whether the stent goes in easily. And then if you have a long stent, yes, 100% I think you need a post-dilatation. Though in early days, we were all against the idea of doing a post-dilatation acute MI. Professor Giuseppe, I think your views on this, and Katie?
I will let Giuseppe speak first.
Please go ahead.
Giuseppe?
You're muted.
You're muted, Giuseppe. You need to get unmuted.
Yeah, okay. Just I do post dilatation. If there is, it is not well expanded, I do post dilatation. 18-20, I do that.
But the challenge that we encounter here in India is many of the patients, they do come late to the hospital. In your center, probably they have angina, they reach the hospital, the thrombus burden will be significantly less. You wouldn't encounter significant amount of slow flow following post-dilatation. But in our country, wherein patients who come late to our hospital, the thrombus burden is bit organized and you do post-dilatations and all, we tend to see more and more of slow flow.
True, Deepak, if you remember, sometimes here it's one situation where better may be the enemy of good. You find a good flow after the stent, and after that you just do one more dilatation and it's the worst of flows after that. We find this quite often. So I would say 14 atmospheres and not more than that, at least in acute MI post-dilatations.
Yeah, I mean, your point is still well taken, but sometimes if it really doesn't open up, you are forced to.
I agree.
Yeah, I think there's just another interesting thing which we have been doing of late. You know, most of when you see the contractility of the heart, there's a brady there. So when they need an inotropic support in a right coronary, I tend to keep even adrenaline support, and it works well. In fact, we have seen that the slow flow comes down drastically. I'm talking about an IV adrenaline going there as a support. This works well, and then you really the hemodynamics are better. And so I don't know, what is the philosophy? Do you use only norepinephrine or?
No, In a case like this, where there is bradycardia and hypertension, we often give intracoronary adrenaline. And
So that's a different thing. That's the slow flow part of it. What I'm asking is a routine support. Let's say somebody comes 60s, 70s with a bradycardia, inferior wall, complete heart block, and you're taking up the lab. Everyone started norepinephrine. There's norepinephrine, no doubt about it. But keeping a IV this thing works. In fact, this is what some of us have seen. I think we are running out of time. We've got another.
Can you just, Anand, can you play it?
You know about together? No, ready?
I think this was a second stent because the first stent was cut short at the proximal lesion. So we thought we'll put another additional stent to overlap. One stent was not really covering. It is not basically done for minimal lesion. Even the first stent was
showing too much inside.
off the way in the proximal lesion.
Back. No, ready? So once again, we'll check now. Still, I think a lot of overlap. Yeah.
I think we took some time for the precise overlap. We didn't want to have much. So we took that stent boost. Proximally, we wanted to land in a healthy area. Distally, we wanted to be less, wanted to avoid much overlap.
I think that's good, ba? Hello. Yeah. I think the position looks okay now. No, all of this stent boost purra.
You can forward it on a little bit forward. You can. Yeah, enough. Stop.
Okay.
Play further.
Okay. Go. Deploy.
I think it was deployed with the.
Yeah, and you can forward
okay,
this.
Anand, can you forward some more?
Multiple times we took a stent boost. Yeah, it overlapped.
Yeah, play from here. Yeah.
Dilatation with a 3.5 balloon.
This also you can forward little slightly. Yeah, forward. This is all post dilatation. We did once again a post dilatation, whole lot of the stent.
So regarding the slow flow situations, most of us we would prefer using nicorandil sodium nitroprusside inside the coronary with the help of aspiration catheters. Dr. Joby has got huge experience with lot of intracoronary adrenaline, and his experience how he encounters ventricular arrhythmias with adrenaline. Can you just highlight on this, Dr. Joby?
Especially cases like this with low BP and bradycardia, we do keep adrenaline, and sometimes we might get non-sustained VT, and it's very rare that we have to shock a VT when giving adrenaline. We start by giving something like 50 micrograms initially, and we wait for a few minutes, and if the flow doesn't improve, we might again give intracoronary adrenaline 50 microgram more, like that. And the main concern is arrhythmia, but we don't come across much arrhythmias needing to be shocked. Again, when we give this small bolus of adrenaline, that increases the BP and heart rate and contractility. That also might improve the slow flow, especially in cases like this. And I'm a bit skeptical about giving nicorandil in right coronary artery because nicorandil has sometimes come across, because it's a potassium channel opener, can repolarize the AV node and cause transient AV block. I have at least 4 or 5 cases where we had AV block with transient AV block with nicorandil. I don't know what's the experience of seniors and colleagues out here with giving it intracoronary nephronatal and right coronary arteries.
Yeah, you are agreed. Sometimes when you give it a very deep inside, closer to the AV nodal branch, you get this even. How often you guys differ post-dilatation for the want of avoiding a slow flow, no flow? Like deferring a stenting, thus we can adopt the policy of deferring a post-dilatation, do it on a different day?
No,
I don't do it.
Something
We often keep this intracoronary nitroprusside or adrenal before post-dilation because before post, because by giving adrenal node SNP that might open up the microvasculature, and so when we do the post-dilation, all this plaque would, all this micropulp would be washed away. So it's better to pre-treat than to post-treat after post-dilation to prevent a slow flow or no flow.
And
I think in an ideal world, we should actually do that. That you put a stent, don't do post-dilatation, bring them back in 24 hours and optimize the result. But unfortunately, we don't live in an ideal world. Because what I'm saying in 2020, when there's no excuse for us to do primary PCI just in a half-hearted way, just put a stent and come out. That's what most of the time we end up seeing patients. We put the stent in primary PCI. We say it's primary. We just want to put a stent, establish flow. But that doesn't mean that 6 months down the line, this patient can come back with an ISR. Because half the time we know the size of the stenting in acute coronary, in primary PCI is actually much smaller than the size of the artery itself. So I think this is a big debate about whether we are truly doing our consciously doing things in primary PCI. So I don't accept the point that in primary we just need to put a stent, we establish flow, get out. If that is the case, we should bring them back in 24 hours to make sure that we optimize.
I fully agree. Once you place a stent, you must work very well. Otherwise, you just do balloon pre-dilatation. You can get a good flow with just balloon pre-dilatation as with capacity.
Excellent.
I fully share this
If you
opinion.
stent, you must put it correctly. Otherwise, you risk stent thrombosis. So this is one big issue, not restenosis, but stent thrombosis.
Yeah,
especially in this case.
Yeah, I think jobbing your point where I've also been using a lot of intracoronary epinephrine. Well, the only problem that we have seen is we have had few cases where they went in for VT, VF. It really goes up, drastically. And we had one patient had an intracervical bleed. So I think that, but then it's a miracle. I mean, sometimes it's so wonderful that the slow flow disappears just like that. Other thing which I've wanted to talk to you about is intracoronary adrenaline. Sometimes you see the ST going up immediately after the intracoronary nicorandil. I mean, it's very transient, comes down, and then but I think the other message that, just before you do a post-dilatation, maybe you can use your vasodilators and tirofiban or whatever. So that really also helps the cause.
Okay,
but I think you must. I think that's very important. When you put in a stent, you really have to do a decent job. Otherwise, the patient is going to come back with a shock.
I think one should optimize the stent. The moment you put a stent, one should optimize.
Absolutely.
Yeah.
But whenever we are doing the aggressive post-dilatation, we keep on end up in the no reflow. So what is the role of, again, the stent balloon dilatation 1 or 2 times at the 16 atmosphere, and we can get the good result? What is expert comment about, again, the post-dilatation with the stent balloon?
There was LCX disease as a non-culprit as well as next.
I think
osteoproximal LAD, which we are planning at a later date when she comes out of this STEMI syndrome. Next slide.
I think this is a summary.
So
when you use balloon, sometimes you can have an edge
So this is how we worked on this RCA. This was pretty anomalous. Moment we wired, we did a thrombus aspiration. We got the vessel immediately, but we started noticing lesions in the distal RCA, which looks like minimal. There was a tight stenosis in mid RCA. There is another haziness with the lesion involving the proximal RCA, and closer to the guide, and another lesion was there. So we gave additional thrombus aspiration. We gave intracoronary nitrates. In fact, we even dilated the distalmost vessel, and we dilated the mid and proximal lesions. So during which again the flow got occluded. The patient became very uncooperative, restless. Luckily, we had an intensivist to help us to stabilize the patient. Once the patient was reasonably stable, we got her coronary hooked again, and we did a quick thrombus aspiration again, another balloon dilatation. Now the vessel is started appearing again. Now, as we already read the RCA earlier, we decided to stent all the proximal lesions, mid proximal tandem lesions, with one stent 48, which was not covering. So initially it was 348. Subsequently, it's another 318 was overlapped with the earlier stent. The entire stent This is a second stent overlapping with the earlier stent. Next. Then next. We took a very meticulous time to make sure it was well covering the lesion, sitting at approximately in the normal area with very less overlap. Once it was done properly, then we went ahead with the post-dilatation with a 3.5 balloon all the way involving all the stents, 2 stents overlap area from distal to proximal. We went even up to 20 to 24 ATMs almost throughout the RCA. So this is a final angiogram. Next.
Well, sir.
Yeah, I think we are running short of time. So, any quick comments from our moderators, the co-moderators, and the panelists?
This is what final angiogram, guys. STEMI, total RCA, stented proximal to mid the vessel.
Just another few seconds only, Deepak. Just wanted to show the ECG, next day ECG.
But this bradycardia was still
show the
persisting,
EKG.
right?
So what is the role of
by
TPA
4
in this
hours, you
case?
can appreciate well settled the ST with the T started inverting, and you can see the echo now in a parasternal long axis view. There is a basal inferior wall is hypokinetic. Overall LV function looks good. There is some change in axis now. You can appreciate now again the mitral cooptation is looking good. Again, the basal inferior septum looks hypokinetic.
I think we can move
some
it.
trivial to mild MR.
Yeah, move, Anand, move it.
RV looks.
Yeah,
The next
quick
day
comment from
morning,
our
the
co-moderator.
previous night, she was jumping with a lot of pain. Now she is quiet, more relaxed and comfortable, sitting nicely. It all shows well settled ECG, preserved LV function, very quiet patient, tells us the story of how great the primary PCI and important to her. At this juncture, I thank the entire team involved in this live in case box, from Abad Vascular, Mr. Palani, from audio visual team, Mr. Pradeep, and my fellow Dr. Arun, who was really getting this patient to me on this night. And my cath lab which works by 24/7, my cath lab nurse Divya and my cath tech Mr. Prakash. And foremost, my sincere thanks to Dr. Deepak Davidson for this Conquering Coronaries webinar, as well as giving me an opportunity to show this case as a live in box. And I appreciate his wise thought of bringing this primary PCA as a case in box. Thank you, one and all.
Thank you, Shiva. I think we are running short of time.
Yeah, absolutely. Sorry.
Go into the any further comments?
One of the things I also use the intracoronary adenosine, and in the distal bed, we haven't discussed much about it, but I do use 60 microgram. It can go up to 120, 150, but we have to be very careful, as we all know, the AV block, transit AV block.
Yeah, particularly when you have a TPA on board, you can confidently give adenosine now.
I agree with adenosine. I do distal injections in order to avoid AV block. I go distally with an over-the-way balloon, or with the thrombectomy catheter. I go into intraventricular branch and posterior branch and the posterolateral branch distally, in order to avoid AV block. I do infusion 60 micrograms every, let's say, 15 seconds. So I do an infusion of a full ampoule of adenosine.
Thank you. Thanks very much for.
How often the panels? Only one question. So I think how often in inferior LMI who has pre-procedural bradycardia or with venky backing, how often do you all think that the venous line is important? So that sometimes distal embolization, almost the RCA was closed at that, but after opening it got closed. Suddenly these patients will go in for third degree AV block, complete heart block, hemodynamic instability. Do you routinely practice having a venous line, at least if not a TPI, in your routine practice, especially in a patient who has a bradyarrhythmia before your PCI?
Good question. I think I sometimes do that. Put in a venous sheath, and then we are all set. You go radial, finish off the procedure, and the need for a TPI is very limited these days. Until the patient
get the artery back before you put the TPI. Get the artery back.
Yeah, and at least another aspect of the advantage of having a venous sheath, particularly in the right.
At least venous sheath, I would say, rather than
Yeah, you want to give a lot of fluid rather than small vein for your nurse somewhere. Venous sheath accepts you to give a lot of fluid very quickly, particularly in inferior LMI, in the cardiac.
Agreed. My experience, I use the guiding cutter. I push the wire distally. I pull the guiding cutter into the aorta and just inject a little bit, a lot of fluid through the guiding cutter without taking the vein. It's what I do if in case there is a hypotension.
Great.
Perfect.
Yeah.
I think a lot of other ways to. How to skin a cat, everybody does in their own style.
Time is important. Ischemic time is important. If you have somebody in 24 hours after a myocardial infarction, the complete air block is not going to disappear even if you open it. You might need a temperature.
Perfect.
A lot of things which we routinely practice. I think we had a wonderful show. So shall we just go to the guest lecture right now? Can I invite Dr. Elvin Kedi to give his presentation? We are absolutely on time, I suppose. Yeah, just 5 minutes late. Yes.
You see my slides?
Yeah, clear.
Excellent. So my talk will be moving a bit out of the STEMI, but it's actually still again on plaque ruptures, plaque progression, role of FFR and OCT and all this. And it's going to be a bit of so I'm going to share some slides that tries to give some answers to studies that we've seen appearing recently. So the FFR concept evolution started with the DAY-3 trial, which basically says that PCIs, that patients that have a negative FFR do well on medical treatment, where patients with PCI, and they have also similar outcomes with PCI patients. But however, the concept of FFR started living from when we moved it from the single vessel to multi-vessel disease with a FAME trial, which says that FFR guidance, it leads to better clinical results at angiographic lesions. And then we have another change into the logica of the FFR, and it moves from a tool that defers to a tool that mandates PCI. And that was done with the FAME-2 trial. And the FAME-2 trial, what did it show is that PCI of all FFR positive lesions is better than OMT alone, but again, this was driven only from about 20% of acute revascularizations. So I think that FFR is a smarter way of revascularization, mainly because it reduces angina. So if we look back to the FAME-2, as I said, the main result was driven from these urgent revascularizations, but there were no difference in myocardial infarction and death. And then again, if we look to the further trial, the ischemia trial, we also have no difference in death NMI, but also here we had a 20% crossover again. So the similar rate of 20% is seen in both of these trials. And these are patients that actually need revascularization. Now, what are these 20% of patients that have this crossover? These are probably two types. These are the ones who are severe in baseline, but really severe, less than 75 or less than 0.70 even. And then there are some patients that had intermediate lesions with FFR that was negative at the time, but they had a progression through the follow-up. And if we look to the FAME-2 5 years result, there is some improvement in myocardial infarction, and that starts after the third year. And if we look again, one important lesson that we have from ischemia trial, that here, if we look to the spontaneous MIs, there is a significant reduction in spontaneous MIs. But then again, we'll see that there are also myocardial infarctions occurring in the group that had a positive, that had a treatment for ischemia lesions. So the question is, why are these 70% of infarctions happening here? So where these infarctions are coming from, if we have treated the ischemic lesions, where are they coming from? And then we come back to what we have learned from histopathology. We know that there is a progression of plaque that starts here when the plaque becomes vulnerable, it ruptures, it creates a thrombus, and either it gives an occult or overt acute coronary syndrome, or it heals and it gives you a stable or crescendo angina. And actually, this is the moment that we will get these patients for FFR. And as you know, 1/3 of these FFR will be positive and 2/3 will be negative. So whatever we do, when we do an FFR, 2/3 of these lesions are left beyond and are put on medical treatment. But we know that in some of these lesions, it's not that they rupture and heal, they have a persisting inflammation, they have vulnerable plaques, whose prevalence we know is about 20 and 40%. And the question is, what is the relevance of these plaques? So, as I said, let's look to some maths. Whenever we do an FFR, 1/3 of the patients will be positive and 2/3 will be negative. So it means that 2/3 of the potential vulnerable plaques remain untreated, so about 70%. And this is exactly what I look to with this curve when I look to the spontaneous myocardial infarctions from the ischemia trials. This is what explains these infarctions that happen in the invasive group 2. Now, we have very interesting studies coming from the group of Japanese and Korean collaboration, and they look to patients on CT. And again, as you could see here, they look to patients that were FFR negative and positive because they took these patients on the cath lab. And again, you could see that 1/3 of them was FFR positive and 2/3 of them were FFR negative. But as you could see, the vulnerable features were of course, more present in the FFR negative lesions, but in absolute numbers, they were more present in the FFR negative. So again, as you could see here, you could see that there are, for FFRs that are severe, also it goes parallel with the vulnerability of the plaque. But if you look to the absolute numbers that are left behind, 2/3 of these plaques that are vulnerable and they are at high risk are in lesions that are FFR negative, and 1/3, so you could see 40 and 20, 1/3 is in patients that had FFR negative. So as I said, 2/3 of these plaques are left untreated. Now, how does this translate in event rates? As you could see, the majority of the events rates in numbers occurs from the patients that were FFR negative. And if we look to this next slide, here are the patients that were FFR positive and were treated. And you could see that here are the patients that were at 3 high-risk plaques, 3 criteria for high-risk plaque, and they have a higher rate of events. And on absolute numbers, you could see that this difference started here at 2 years and was maintained up to 3 years. So these patients who have high-risk lesions, they will have also a worse outcome than the patients that were treated. And also in absolute numbers, you could see again about 20% of events are coming from these patients, and this is twice as much as patients that are being treated. So the majority of events originates from FFR negative lesions with high vulnerability features. Now, can we identify vulnerable plaque in the cath lab? Yes, we can, because we have now OCT, and it can give you a perfect resolution and clearly give you the insights of what we need to know for a vulnerable plaque. So the thinca fibroaderoma, lipid presence, microvascularizations, and macrophages. And in the combined trial, we looked into this and we found that the impact of having of a vulnerable plaque, particularly a TICFA, gives you a 5 times higher event rate despite the lesions being FFR negative. So, as I said, 5-fold. So if you are FFR negative and you do not have a vulnerable plaque, you have an excellent outcome despite these patients being diabetics, where the patients that had TICFA, they had a 5-fold incidence of events. Is it combined the only study saying this? And I say no, because there has been also a very nice study from Kubo who showed that the majority of patients that had events originated also from lesions that were TICFA positive, and particularly lipid-rich and TICFA positive, where lesions that did not have these characteristics had very good outcome. If you look at these curves, they are very, very similar to the curves that we found in the combined trial. So basically what we know is that having a plaque burn and TICFA is associated with a higher rate of events during the follow-up, so up to 33% of these patients will have a new acute coronary syndrome during the follow-up. So I come back to what I said before, and that is when we come to this point and we have these vulnerable plaques and persistent vascularization, that's what's going to give, again, new acute coronary syndromes. And for this reason is why physiology alone is not enough and imaging should be considered into this patient. So my take-home message will be that FFR-guided revascularization significantly improves symptoms, however, not sufficient for significant reduction in acute coronary syndromes, MI, and mortality. That the lipid-rich and TICFA lesions are at high risk for future events independently from ischemia. And now, should we treat this lesion or not? We do not have an evidence for this, but I think this is where we're heading and what we should do in the next years.
Thank you, Dr. Kedi, for a brilliant lecture. I think you have brought in a lot of insight into the acute coronary syndrome. In fact, I have a question to you now. When we treat a lot of young patients these days, more so in the COVID era as well, we tend to see just a thrombus and, it maybe just a plaque corrosion. So does it make a real sense in having an OCT in all patients, particularly the younger group, where we sometimes defer a stent and still we really do not know about the vulnerability? It might look little, these are not stenotic lesions, but then sometimes, there's just we leave them, but at times they come back with an event later on. So do you think OCT in that scenario also helps?
I think it helps. And we, as I said, we do not have the data yet for this, but the data are coming in a retrospective way, as I showed from Dr. Kubo. What we know is that what you need to have and what is a real vulnerable plaque is not only the presence of lipid, but it should have a necessary burden. However, every lesion that we're considering doing an FFR has a average diameter of stenosis visually of 50%. So if you translate that on plaque burden with the concepts we have from IVUS, they are all having the necessary plaque burden. OCT will tell you if they have lipid or not, and this is with a quite good accuracy. But lipid alone is also not enough. Having lipid, it augments your risk, but having lipid and TICFA, as were shown in the slides before, this is where your event rate really goes high, because these are lesions that have the plaque burden, they have the minimum lumen area, they have the thin cap atheroma, they have the macrophages, they have ongoing inflammation to this necrotic core, and these are all factors that will make that these lesions are at a higher risk for vulnerable patients. If you don't have this, you could be safe. This patient will do quite good, especially if there is no lipid at all. Even if it's stenotic, you could try to treat this patient medically.
Yeah, we also know the limitation of FFR in acute myocardial infarction. So I think combining this two will be a big boost in terms of knowing, the problems further and then tackling it. Any comments from my co-panelists, Professor Gazip, who would like to add something there? Dr. Anil?
Yeah, actually, this will be a major decision making in acute coronaries, non-STEMIs. You take up the patient, you find a borderline lesion. Now, if it is, Dr. KD was talking about the 50%, but if it's 60 to 70% and you do an FFR, it's negative, you leave them on medical management. Whereas, is it different from the 50% which you just leave it? Should you stent them or should you leave them? That's always a tough call. And second thing, this vulnerability, medical management should take care of it. Ideally, in an ideal world, statins plus antiplatelets should take care of the vulnerability. There was that concept of stabilizing the plaque by stenting that is no longer valid, I think. Your thoughts, Dr. Kevi?
Yes, but as I said to you, the slides before from the groups of Japan, where they clearly had all the necessary tools to put these patients on statins and absolute medical treatment, still they had a 30% event rate on not need for revascularization, but acute coronary syndrome, which in my occasion is good to prevent if we are trying to treat these patients. So I think that there might be a rationale for stenting too. There might be a rationale for different, more aggressive statin treatment. Both of these options, we don't know which will be the best, but I think this is food for new thinking. We have evidenciated a problem, and now we have to do the necessary trials to see which is the best way to solve it. As I said before, we had a question from one of the reviewers. The paper is now accepted in European Heart Journal, and one of them is, what would this change? The fact that we know that this vulnerable plaque gives you a problem. How would it impact the guidelines? And the answer I gave is that the actual guidelines mention 41 times the FFR, 22 times ischemia, and 0 times vulnerable plaque. after what we found and what the others found, is that at least we should put this, that it has something to do with the new events. And now it's time to see how we take care of it. But it should be it should be at least mentioned that it's there and it's posing a problem. We expose the problem. We cannot also expose the solution. That's a new trial and new ways to think of it.
Maybe, Anil, I think there is something about inflammation creeping in. I think that's again one problem we always neglect. We don't know. I think we just a I mean, conceptually something new which we need to address, and then you'll always come out with solutions. I mean, brilliant.
I wish I knew, but I don't. I wish I knew, but I don't.
Normal coronaries with plaque erosion can be there. When you do OCT with a patient with non-STEMI and the normal coronaries, you find only a plaque erosion. That also leaves a lot of scope for medical stabilization, I feel.
Yeah, that's a question which I put forth. Yeah, Dr. Rafiq, you're muted. You're muted. We can't hear you. You're muted, Doctor.
Sorry, if I may ask. So if you have a young patient where you have a thrombotic burden, you aspirate, whatever, you got a good TB3 flow, and you do have an OCT which showed there is a plaque erosion, as we discussed just now, that you leave them alone without stenting. Now, what is the role of FFR, and what is your time frame if you want to do an FFR for this culprit artery? How long is the time frame for you to do the FFR back again in this particular patient, or would you not just do it anything at all?
Well, in acute coronary syndrome, especially if we're treating about culprits in the acute phase, there's no rule for FFR. The OCT time frame depends on the mass of myocardial infarction you get after. If we're talking about a slight troponin increase, then you could eventually do it that moment too. But if we're talking about big myocardial infarctions with a lot of transmural infarction, what do you need FFR for? You know, most of it is, what are you trying to do? All you need to know, if there is some viability on that muscle that is left there, is there makes sense to still put a stent on these patients or not. What is the role of FFR in, let's say, plaque erosion, of OCT in plaque erosion? I think you have to know why this plaque erosion is happening. And the answer I'll give, it's an assumptive answer. I don't really have data to base, but I think that has to do also with the minimum lumen area at that level. If the minimum lumen area would be smaller than 2.5, then I will consider it for treatment. If it's still a large lumen and you just have occasionally some thrombus there, then on medication this could do good. So I think it has to be also a cutoff of the minimum lumen area that should be taken into consideration.
Just to put forth the question again, what Anil has asked, does this mean that we should do an OCT in all FFR negative patients for both TGFA and LAP?
Well, that is a very important question, because I think if we prove further that OCT it's more important because it's showing you 2/3 of the patients that have events instead of the FFR that's showing you 1/3. I think we have to divide this concept. FFR is showing you which lesion is causing you pain, point. And the OCT is showing you which lesion is going to give you a problem, independently if it's causing pain or not at that moment. So these two concepts should be separated from each other. Once you separate these two concepts from each other, then the good news is that the new devices will have incorporated OCT and FFR in one. So I think we might move out of the concept of having ischemia, doing bicycle tests, but I think the high-risk patients, the diabetics, the genetically patients with high cholesterolemia and strong genetic or familiarity for acute coronary syndromes, they should undergo CT scans and see the amount of burden of plaque they have. And if you want to treat patients in a good way, my way of the future of treating patients is forget bicycle tests, do a good risk profile on them, put them on CT and find out what kind of plaques they have. If they have a lot of burden, then it's necessary that they come to the cath lab and you do a good analysis on OCT. That's a way, in my opinion, to reduce myocardial infarction, to reduce patients only presenting with 3-vessel disease, and the only we could do as cardiologists is to send them to the surgeons. I recall you what happened in the FREEDOM trial. The FREEDOM trial, when we compared these high-risk diabetic patients with 3-vessel disease into between PCI and CABG, of course, CABG will win in that situation. The question is, how comes that 80% of these patients that underwent, that went into this trial was the first time they had an angiography. Where were we till this three vessel disease instaurated itself there? So this is the message here. I think we should get these patients earlier and get them in treatment earlier.
But does it mean that, one final question to you, does it mean that we have an OCT imaging on all ACS patients? So is that the future? To make a decision.
Well, I think if there are high risk patients, yes, that's where we're going to move. Maybe it looks too futuristic right now, but I think let's have this discussion between here and 5 years. I think that's this way.
Forward, yes. Any further questions from any of my co-panelists or moderators?
So we have a country like India, we have a lot of thrombolysis patients come with MI. Next day we are doing angiogram showing recanalization LAD. We have tendency to do the OCT. So what is your think about post thrombolysis, angio-based recanalization? If you do the OCT, lot of ugly block burden more than 60% like that. But angiograms look like recanalized. What is your comment regarding the management?
I cannot answer this question because in my country we're not using thrombolysis from a long time. So I don't have experience with this, and I tend to give opinions when I have experience and not just talk about things I don't have this experience.
Yeah, so I think thank you so much for your brilliant talk and given us a lot of new to think about. Dr. Deepak, I think we go to the second guest lecture. We're right on time.
Yes, sir. Yes, sir.
Dr. Gazip, I think are you ready with your presentation?
Can you see the screen?
Not yet.
Not yet, sir.
Can you see?
No, sir. No, it's not shared.
Let me try again.
You have a green thing there.
Yeah.
Screen.
Going.
It's just about coming up. Yes, sir. Could you go to the slideshow, please?
See now?
Yes, sir.
Excellent.
Okay. Dear Chairman, dear colleagues, it's a great pleasure to be part of this very nice meeting. Congratulations for the organization. I will talk about DAPT in HBR situation and just looking at the COVID scenario. We know that DAPT is a key element to prevent ischemic events after PCI, and we know that stent thrombosis is due to several factors and lesion factors, patient factors, and also stent. It's a stent-related complication. And these are data, especially in the setting of acute myocardial infarction. This is data published years ago, 2012, showing that how first-generation drug-eluting stents were associated with the negative risk of stent thrombosis as compared to bare metal stents. And we know that stent thrombosis has a significant dramatic impact on on survival, and you see also in the late phase between 30 days and 1 year still 21% mortality. Part of this issue has been solved by individual patients' data meta-analysis. I would like to thank Alvin Cady and Gregson for cooperating with me on this paper, and that there was a significant reduction with science in terms of stent thrombosis as compared to third generation DS in the setting of acute myocardial infarction. And especially you see within the first year. And however, we know that DAPT is associated with an higher risk of bleeding, and high HBR population is an increasing proportion of patients, especially due to the elderly patients. And we know that it is important after PCI to avoid hemorrhagic complications in order to further improve clinical outcome. We know that bleeding has a significant impact. This is a nice paper from Maran years ago showing that how wild the impact of MI goes down from time 0 to after 30 days. For bleeding, there is still an higher impact of mortality even after 30 days. The impact of bleeding on mortality seems higher than than myocardial infarction. And this is even more important. The risk of bleeding is even higher in patients with a new ADP antagonist. You can see in the Triton and Plato, the risk of bleeding went up by 30% as compared to clopidogrel. So let's have a look also at the COVID scenario. We know that this is a paper published months ago showing that in patients with undergoing primary PCI, patients with COVID positive patients had a significantly higher rate of stent thrombosis. There was a higher rate of thrombus burden, larger thrombus burden, and impaired reperfusion. And I'm glad to share with you this data from the registry. I lead it, and I would like to thank also having to taking part to this initiative, big initiative. And now we have more than 70,000 patients from 109 centers across the world. And in this first publication, we found that the patients treated in 2020 were significantly lower. So there was a significant reduction in numbers of primary PCI in 2020 during the COVID phase, especially in patients with hypertension. There was a longer time delay, and there was a significantly higher impact on mortality, even after the exclusion of patients with COVID positive patients. In fact, in our study, this population had a very bad outcome. This is a sub-analysis in COVID positive patients. They were randomly matched with 1 to 5 with 310 patients, so overall 372 patients. We found a significantly higher rate of mortality in these patients, touching 30%. You can see the beneficial effect of thrombectomy, especially in COVID-positive patients, in terms of mortality. And you can see the significantly higher rate of stent thrombosis, touching 8%. And you can see the impact, the positive impact of thrombectomies in this population in terms of prevention of stent thrombosis. So we know that the COVID patients, they have an higher risk of thrombotic and thromboembolic complications, but they have at the same time also an higher risk of bleeding complications because they are complex population with several comorbidities. They may have thrombocytopenia and they use anticoagulation. And concerning the new trials on next generation DS have shown an acceptable safety profile with short-term DAPT. However, the optimal duration enabling in bleeding risk patients, especially in ACS, is still a matter of debate. And these are the guidelines suggesting, and this is the flowchart supporting from the recent European guidelines. They introduced a new category of very high risk bleeding patients. So these are patients needing with a recent bleeding or with a planned not deferrable surgery. In this population, they considered even in ACS 1 month DAPT, in high risk bleeding patients 3 months DAPT. Whereas in patients at low risk for bleeding and higher risk of ischemia, they recommend 1 year DAPT or a combination between 3 months DAPT and ticagrelor alone and plus prolonged antiplatelet therapy after 1 year. And this is the first one of the first trial published comparing the polymer-free drug-eluting stent by freedom versus bare metastent with 1 month DAPT. There were 2,400 patients. They met the primary endpoint. There was the biofreedom performed much better than the BMS. And however, there was no difference in terms of stent thrombosis, but you can see that the rate of definite and combined definite and probable was still high, 2% even in biofreedom and BMS patients. This is another paper, the Onyx 1 randomized trial comparing biofreedom versus Onyx. And you can see that the primary endpoint was a met of non-inferiority versus biofreedom. However, overall, the Onyx did not perform in some way better than biofreedom, and this is what quite sad. I mean, and there was an higher rate of even post-procedural myocardial infarction with the Onyx, and there was no difference in terms of major adverse events. Let's have a look at the science. All you know, the stent, you know, the platform, the polymer coating is a durable fluoropolymer coating, and the drug is everolimus. You have already seen this slide. This is an analysis in the patients with primary PCI, and we found a significant improvement, a reduction in terms of set thrombosis as compared to first generation DS, especially within the first year. Let's have a look at the data about short DAPT with Science. This is an analysis done by Genere from the science family, and they looked at patients. They were divided according to the interruption of DPT within 1 month and later than 1 month. So patients with no interruption, with the interruption, you can see the clear impact within 1 month, but there was no difference between 1 month and 1 year. These are data from the stop DAPT patients treated with 3 months DAPT, and you can see the very low rate of ischemic complications with a 0% definite probable stent thrombosis. Let's have a look at the science short-term DAPT program. There is the 3 months DAPT and 1 month DAPT program, and the 3 months was restricted to USA, and the 1 month DAPT, there was the global population and the USA population, and they were compared with the aim of this study was to evaluate the non-inferiority in terms of ischemic events and the superiority in terms of bleeding complication as compared to another population, the historical science population. And so there was a non-inferiority in terms of safety and superiority in terms of bleeding complications. And this is the sites who took part to these big trials. And these are inclusion criteria, clinical inclusion criteria. They were, you can see age, there was a renal failure, need for oral anticoagulation, low hemoglobin, and so on. These are angiographic criteria. These are the exclusion criteria, the key exclusion criteria. So patients with the 90 days group and 28 days group, and the 28-day group, they received the aspirin after 1 month, and so they took patients who were free from events at 3 months, and patients were free from events at 1 month, and in this group of patients, they were only treated with aspirin, and they were compared with an historical population up to 6 months follow-up. So in this, in the Science 28, the follow-up was the outcome was between 1 month and this 6 months. In the 90 days group, the outcome was between 3 months and 1 year follow-up. So these are the characteristics, patient features. Most of the patients, as in all other trials, were mainly elderly patients and patients taking anticoagulation. So let's have a look at, this is the historical population, the Science 5 trial. And they selected the population that were compared with the patients, including in the Science 28 days and the 90 days group of patients. They were stratified, and you can see that there was they used a propensity score analysis, and you can see the outcome, and it was quite similar between Science 19 patients and the patients treated in the Science 5. And it was non-inferiority was met in terms of death and myocardial infarction. And these are the data from patients 28. So there was no difference between the patients treated with 1 month and patients with treated with standard APT in terms of major ischemic, so death and all death and myocardial infarction. So also in this case, non-inferiority was met. Let's have a look at secondary endpoint, especially BARC bleeding complications. There was superiority met for 90 Science 90 group in terms of BARC. The Science 28. When they looked at the BARC 3 to 5, however, there was a significant improvement reduction in bleeding complications in bout with a short DAPT in bout Science 90 group and Science 28 group. And the rate of stent thrombosis was very low. You can see was 0.2% in Science 19, and the very low also in the group Science 28, 0.3%. Similar to patients treated with prolonged DAPT. So in this study, they showed the feasibility of 1 month and 3 months DAPT as compared to 1 year DAPT, non-inferiority in terms of major ischemic endpoints, and the superiority in terms of bleeding complications, especially in terms of BARC 3 to 5, and the rate of central thrombosis was very low. These are new trials going on. There is the MASTERDAPT, and this is the trial design, and these are the baseline characteristics of patients included. Also in this group, you can see that that the age is certainly the largest proportion of patients, and also patients with oral anticoagulation. So in conclusions, high bleeding risk patients represent a high risk population, and so far several randomized and non-randomized clinical trials have shown the safety of a short DAPT regimen, 3 months and 30 days strategy with new generation DS. I think there is in some way more evidence at the moment with the science who compared with in historical population, whereas in other trials they compared with Bermetasend or with there was a comparison between Biofreedom and Onyx. However, we must realize, because we saw the new recommendation, the new definition of high bleeding risk has been a little bit changed, and especially age older than 75 has begun a minor criteria, and therefore probably future randomized trials are needed with the new criteria recently published, and especially in the context of ACS. And due to the higher risk of central thrombosis observed in COVID patients, I think that extreme caution should be paid in this population concerning the selection of optimal DAPT strategy, especially short DAPT strategy. Thank you very much for your attention.
Thank you, Professor Gizip, for a very enlightening talk. I think it is really massive data on STEMI from during the COVID era. In fact, I believe this is the largest data which is available in the COVID times on mechanical reperfusion. And I think bringing back the discussion whether you showed that thrombectomy really worked in this group of patients. So the question of this coming back into a PAMI in the primary angioplasty era. So I mean, again, reinforces the statement that there are situations where you still have to use the thrombectomy device in acute myocardial infarction. Any questions or comments from my co-panelists? And Anil, you?
Yeah, my first thought was, in this COVID era, there might be an indication for anticoagulation also, especially you showed subset of patients who have D-dimer elevations. So post-COVID angioplasties along with DAPT, if you have to give an anticoagulant also, that will also be increasing the bleeding risk. What are your thoughts on this?
I fully agree with you. What I said, now we don't have a specific date on that, but as you said, now most of the patients with COVID, and they are treated with anticoagulation. There are ongoing new trials with the new oral anticoagulation therapies in COVID patients. So this will make the situation a little bit more complex, absolutely, because we have from one point a high risk of central thrombosis as compared to the historical population. On the other side, we have oral anticoagulation that may increase the risk of bleeding. So what to do? Nobody knows. Probably we would need, but I think now with the number of COVID the patients are going very, very low now with vaccination, I think will not be easy to do a trial, but we would need data on that. It's rather difficult. I personally would stratify the patients according to the ischemic risk. If it is a distal vessel, small marginal, of course you try to reduce the duration of the DAPT. But if it is a proximal LED or left main, proximal big RCA, proximal circumflex, I would keep at least 3 months to DAPT, at least.
So would you have an indication for a smaller dose rivaroxaban 2.5 twice daily as was proved in the recent trials for coronary? In COVID situation, would you consider adding that as a smaller dose in addition to the dual anticoagulation?
This is a very, very nice question. This is making the puzzle much more complex because the low dose rivaroxaban is not an optimal anticoagulation. This is a potential anticoagulation for coronaries, let's say, but
I think we also saw the data on action trial, where 20 milligram had more bleeding in action trial. So I think it's always questionable whether you have the potent antiplatelet on one side. Can you combine this with a, let's say, a modest dose of rivaroxaban? So in fact,
But 2.5 is not, let's say, a truly anticoagulation therapy. I mean,
correct.
so we would use at least 10 milligrams. Let's say if you take rivaroxaban, as we do in long-term prevention for thromboembolic events, 10 milligrams. But the 2.5 is not a lot, in my opinion. So it's a complex puzzle.
Would you combine less potent clopidogrel along with rivaroxaban, or can you combine, because we really do not have that kind of a data with ticagrelor plus rivaroxaban, even 10 milligram.
I agree. Then I thank you for the question. The puzzle is complex because we have a multitude of therapies. We have new ADP antagonists, but at the moment there are no data on that. I mean, it's rather difficult to suggest. I would personally, if you do triple therapy, I would use clopidogrel, absolutely. And on the other side, I would choose the duration based on the ischemic risk. As I told you, if it is a proximal LAD, left may, big proximal RCA, I would keep the DAPT a little bit longer.
Clopidogrel plus rivaroxaban is preferred after 1 month, but aren't we worried about clopidogrel resistance? If it's the only antiplatelet, that is also one which keeps worrying me.
You're talking about acute primary PCI plus
after 1 month. After 1 month.
In fact, we had more patients who were on dual antiplatelets, recent PCI within 3 months, and then getting COVID and then coming back to you. So at that point of time, I think it was initially we were all giving only monotherapy when we were combining with that. And as you rightly said, we have even tried out the low dose 2.5 milligram BID, but there is no justification, as you mentioned just now, that it's really not a thromboprophylaxis using a 2.5 milligram BID. So I think this is still open to until unless we have data. I don't know. I think we are running short of time. Any final questions? Any comments from our panelists before we close this session? We really had an exciting session today. Dr. Rafiq, would you like to add something? Can't hear you. You're muted. You're muted.
Sorry. I was just talking about COVID-19. I mean, it's interesting. We also see some vaccination-induced coronary thrombotic disorders. And in fact, we had a very small group of patients. We did an analysis. And what we found is in those patients who had MI within 1 week of vaccination had a higher thrombus burden compared to those patients who presented with the same MI in the same period of time. And also the TIMI flow is actually lower in the vaccinated group of patients, even though the numbers are too small. So this question comes back to the same thing. If you have a patient with vaccination and coming with a young patient with thrombotic burden, how would you go about in terms of your anticoagulations or antiplatelet result? I think that's also a lot of discussion we need to be aware of with these newer anticoagulants. I'm sure nobody has a clear answer for these questions. I think these are all evolving state, and we probably will have more answers as time goes by.
Yeah, the same thing. We have also been observing this. Recently vaccinated 3 days, 4 days coming with thrombotic occlusions. So I think it's still young, very early days before we make any predictions. And so I think we had an interesting session. I'm told that we're running short of time. Dr. Deepak, do we close the session now?
Yes, sir. So, yes, sir. Thank you, sir.
On behalf of this the group, I just wanted to thank all the international faculty as well as my co-panelists for making this very lively. Thank you so much.
Thank you, Deepak, for the invitation.
Thank you, sir. Let me take this opportunity to thank all the speakers, the expert panelists, as well as the moderators for being with us today evening. We now move on to the next session. For this session, we have as panelists Dr. Manoj Sivaramakrishnan, who is a senior consultant cardiologist at Kaveri Hospital, Chennai. Dr. Lijo Varghese, he is a professor at KMCH, Coimbatore. We have Dr. K.P. Suresh Kumar, Senior Interventional Cardiologist at Kaveri Hospital, Chennai. Dr. Anand Kumar, he is the Senior Cardiologist at Lakeshore Hospital. And Dr. Ramdas Naik, who is the Head of the Department of Rajagiri Hospital in Cochin. We have moderators Dr. Sujata, who is the Senior Consultant Cardiologist, the MD of Indus Hospital, Vaishak. And she's a very hardcore interventional cardiologist. Ma'am, thank you for being with us. And we also have Dr. B.R.J. Kannan as moderator, who is a senior interventional cardiologist as well as pediatric cardiologist at Vadamalayan Hospital, Madurai. Kannan sir, kindly take over. Sujata ma'am,
Yeah,
please ma'am.
Dr. Khanna. So, being caught unawares in a primary PCI is really a nightmare, and you have chosen the right kind of cases sharing which will help us in our approach. So, we'll start right away with the first presentation, primary PCI in LM occlusion by Dr. Harish Mehta.
Yeah, thank you very much, Dr. Sujata. Thanks the Allied panels, and thanks Deepak for having me over. So, without wasting much time, we'll straight go to the presentation. I'm going to run through the couple of cases we've done, and then a little bit of not too much. Primary PCI and left main occlusion. We all know left main coronary artery disease is a higher prognostic risk because it may supply as high as 75% of the myocardium. Especially if there's dominance of the left coronary circulation, then it may be supplying more than 75%. And these are randomized clinical trials of PCI versus CABG. Most of these trials are not done in MI situation, or in planned situation. And they clearly told that in selected syntax score cases, PCI may be non-inferior to CABG. And this is a small algorithm which can be used depending on the heart team discussion. That's very important in such patients. So if you have unfavorable surgical factors and then you see the prohibitive or the non-prohibitive risk, this prohibitive risk, you put them on optimal medical therapy depending on the age of the patient. And depending on the syntax score, if CABG is not possible, then you might think of PCI. So it's just a way of looking at left main. I'm going to present to you three cases. This was a lady who had a previous left LAD angioplasty for an acute anterior wall MI in the a year and a half back. He came back with again an anterior wall ST elevation, and this was a situation where she had a clear left main equivalent with an ostial LAD and ostial circumflex, and the circ system being dominant and right being non-dominant. And she clearly had a stent which was put in the ostial, which probably did not cover the ostium properly. So this was a case that came to us at night, and we did not have any imaging. She had this kind of situation, and her LV was about 30-35%. So we put an IBP, we did a NC to the LAD and NC to the circumflex. And then we took a DS 3.5 into short 12 millimeter into the LAD, then did a DK crush. This was the first kissing. And then we took a DES in the LCX 3.5 into 23 and did a report. And we did a final kiss followed by a report, and that was the end result. This was the first case which I'm presenting. Second case was a similar 85-year-old gentleman, acute anterior wall MI. This was the situation again, left main, LAD, circumflex. Again, a dominant circumflex, right is non-dominant. In this patient also, we put an IBP and we did a rotablation to the left main LAD. And we did rotablation to the circumflex. But if you see the ostium of the LAD was still quite bad. We did an IVL, the left main LAD. And then finally stented the left main LAD and a plain balloon onto the circumflex. Since she was 85, borderline hemodynamics, we did not stent circumflex. We didn't want to complicate the situation. We left it because the circumflex result was clean and good, and we thought we'll intervene the circumflex only if we need to. So this is the second one. And the third one was a very interesting one. She was a 92-year-old female, a doctor's grandmother, non-diabetic, non-hypertensive. She continues to present with chest pain on exertion, multiple episodes of ACS, severe ST depression, AVR ST elevation with LVF in the last 2 weeks, and EF was 25%. The granddaughter was insisting that she wants her to be intervened because she wanted to have a normal life. She wanted a pain-free life. This is a case borrowed from my colleague, Dr. Anand Rao. And this is what was done for this patient. If you see again a similar situation, short left main, calcified LAD, calcified circumflex. In this, we planned it differently since she was 92 with an LV dysfunction. We thought that syntax score was more than 35. First choice would have been bypass. Giving her age, nobody would have taken her for a bypass. Second choice would have been a chip with an MCS support. Impella versus using an ECMO. Our team was consulted. Patients and relative accepted PCI with the associated risk and higher risk consent was obtained. And this is the left femoral puncture followed by putting the Impella sheath. But we realized that the iliacs were very badly calcified, which you can see here with some stenosis in the iliac there. So we changed over to a large sheet because the Impella could not cross with the 14 French sheet supplied with the Impella kit. Then we used a long 14 French sheet to negotiate Impella through the calcified iliac bifurcation. You can see how much effort we need to negotiate this Impella through the other side. Finally, it gave way and we could go to the LVA and put the Impella in position with good pumping. This is Impella 3.5. And then we did the rotational atherectomy using a 7F guiding catheter, first to the LAD, and that was the LAD after rotablation. Then we rotablated the circumflex with 1.5 millimeter per 180 RPM. Then we stented the LAD after pre-dilatation. This was the mid-LAD stent followed by an Austell 3.5 into 23 Zines expedition. Then we post-dilated the stent, did a pot with a 408 and L6 was recrossed and the ostium again was pre-dilated. We used the 3 into 12 expedition and L6 tap technique. Did a simultaneous kissing balloon and then we did a final pot. Just at the end, we did an OCT again to see how it looks. And we found most of the expansion was very good, varying from 87 to 104. And good MSAs were obtained 5 distally, 5.6, 7.13, 12.5 almost at the left main. And there was some malapposition in the left main area. So we decided to do a repot with short balloon because you have to be very careful when you do a tap. Your pot balloon should not go close to the tapped circumflex stent. And that was the final result. The Impella was retrieved and the groin was closed. Now, this case, I have never had one, but although I've seen people doing it, this is a primary angioplasty in a catastrophic presentation in acute left main coronary total occlusion trial. This was seen in 0.58% of patients in Atolma registry. It can go up to 2% in most patients. And these patients are low in presentation because most of them do not reach the hospital. And the mortality rates are good only for survivors. Otherwise, the in-hospital mortality was very high in this thing. There are the 58% in-hospital mortality. And there were two factors which decided that atolma and left dominance, which I showed you, all the 3 cases I showed you were left dominance, are generally incompatible with life and they are the riskier ones, especially in the absence of well-developed collateral circulation. So the important conclusion points here are that one, you need a heart team approach. You should have an MCS standby with you. IBP may or may not help. We have had IBP helping us in 2 cases. This was one with Impella and one we had done an ECMO, but we had put an ECMO after the PCI because patient had intractable arrhythmias. So we put the patient on ECMO for 25 days, but eventually she didn't make it. Then you have to be very well prepared to prepare the lesions because most of them have calcified lesions, especially if they are old. If they are young, then maybe you not have any calcified. This Impella is generally an easy to deploy device if you have a good coronary access. So these are the important things. We need a Doppler available in the cath lab for you to assess the vessel size in the vessel before you puncture it, because you have to puncture it very, very well. Otherwise, you might end up puncturing and causing more femoral complications. And if there is imaging available on site, which may or may not happen in many hospitals, is ideal to do imaging maybe after the patient stabilizes. One should not waste time in imaging in the beginning because you might have a hemodynamically unstable cardiogenic shock patient where you cannot waste time in imaging in the beginning. So my approach has been, if you have a young patient with preserved LV function, mechanical circulatory support may or may not be used, but should be available on site. if left dominant circulation is there with or without LV dysfunction, then MCS to be considered upfront. You should use it upfront rather than wait for the patient to collapse, and then you may have no time because there'll be nothing left to salvage. Proper debulking is very important to prevent recurrent MACE. Unless you're in a situation where you want to just bail out and come out and optimize later, ideally intracoronary imaging to be used, provided available on site. And of course, heart team approach, CABG is always an option. Thank you very much.
Sir, are most of your cases NSTEMI, sir? Because all of them.
No. The first one was a STEMI, anterior valve clearly, anterior valve MI. The second one was also a STEMI, that was also anterior valve MI, but fortunately they had flow. And the third one was an ACS. The one with the Impella was an ACS with LVF.
Any comments from the panel?
So first two cases, so what should be your take-home message? Patient has left main disease. Yes, come with acute coronary syndrome. How much importance should we give for imaging? How much importance we should give for stabilizing the patient and taking the patient again after some 3 or 4 days?
So the question is, the first patient came with LV dysfunction, borderline hemodynamic, acute anterior wall MI. So you have to take the patient right away. You cannot stabilize the patient and lose the myocardium. So the decision has to be either you do it, or if any surgeon is willing to do it and finish the job. I don't do imaging unless it's the end, and most of the hospitals may not have imaging available on site. If you have imaging available on site, I would do it at the end when you finish the procedure. You don't want to risk the patient collapsing in front of you. The imaging would be the last tool, but should be there. And if you have clearly calcified, then debulking, you don't have an option. Even if you are there, you have to debulk, otherwise you will not be able to expand your stent. So these 3 things, you have to have a heart team quickly and decide immediately, because they won't give you time. Only the third patient gave us time because she was old and she was in recurrent ACS and LVF. But with MI situation, I think you have to take that call there and then.
Harish? Rotatripsy also you had done, and in an acute situation.
Sorry?
You had done a rotatripsy both.
Yes. Yeah, we have done rota and MI situations in quite about, I've done about 15-20% of patients, and we have to accept the risk of that. There might be slow flow, no reflow. But then you clearly have to put mechanical circulatory support on board and do it. It's not left with much choice there. I mean, you can't do anything if there's calcium. Nothing else is going to help you. You have to debulk it. And some lesions, your cutting balloon will just not go across. You can't do a thing about it.
Harish, a couple of patients we have had calcium, and what we have done is we've done a balloon angioplasty, achieved good PV3 flow, put them in anticoagulation, brought them back and done the rotablation after maybe 48-72 hours. That way you can prevent all this reflow, no flow, because it is catastrophic to do rotablation when there is a high thrombus burden. And we have burnt our hands. We have done that in one patient. We had completely the vessel shut down. And I think rotablation in acute MI is a double-edged sword.
Yeah, it depends on what outcome you can manage with the balloon and what flow you can give the balloon. That's obviously I agree with.
I think Harish is a wonderful case, and I think the discussion points are around the second case where you have to do a rotablation in acute MI. But I think that all be dictated by the hemodynamic response, whether we can defer and bring back the patient later. The patient is symptomatic, and I think it's worth considering a PCI in the first setting itself when you do the diagnostic procedure. But as you said, you may not do much imaging in the upfront, and perhaps consider only after the initial balloon dilatations. But when you do consider debulking devices like rotablation, I suppose that would be guided by the imaging, or do you go by the fluoroscopic calcium and how the balloon behave at the pre-dilatation?
Right. So if the balloon crosses, obviously I would, and if she gives you time or he gives you time, then you should do image after the balloon before you do an ablative procedure. So that will, imaging will also tell you the thrombus burden and the amount of calcium, whether it needs debulking or not. But in situations where even the balloon doesn't go, which I have found in about 5-7 patients, in an acute MI situation, the wire goes, the balloon also doesn't go. They're probably left with no choice but to First do a probably 1.25 rota, create a small space and then do an imaging.
And as regards to the last phase where you had to introduce an impella with calcified iliacs, you can perhaps, if it's available, a peripheral IVL would be a choice, because recently I had to do a peripheral IVL and then introduce the impella in an 83-year-old lady.
Right.
So I think that's a good choice than using a higher sized sheet.
So that's in fact an option we had discussed, because the impella people are the ones who supply the IVL also. They are the same distributors. So we asked him if he had a peripheral IVL with him. He said he doesn't have it. So we were constrained there. And of course, the other option would have been we could have stented that iliac by ballooning it and taking the sheath and stented it while coming out. That was another option we had. But impella, I think people who have used impella, I'm sure, are there on this panel. There's a problem with impella is that you can only take it on their wire, and their wire is not really as stiff as you think it is. It's not support, doesn't give you support. And you cannot, it's not like a exchange wire, like in a, you cannot exchange that wire to another wire. It doesn't even take another wire through. So you have to go only through their wire. That's an issue with impella. So they need to work on this to change, and the system has to be more monorail. They're not monorail system, so the pushability is not there. They need to create a monorail system on impella. I don't know how they will do it with the motor around.
And I just like to, the first case which you showed, that the case came late in the night.
Yeah.
And you went with DK crush, with an IABP and other things. Don't you think we could have just done a plain stenting into the LED from LM to LED and later on looked into it rather than in the late night with the imaging later on?
Yeah. Right, so the reason we did DK crush in that is once I ballooned it, she behaved well, so I knew I had time to do what I needed to do. And she had ostial circ, ostial LED, so I would have had fixed both anyway. I could not have left circ there. If you see the first angiogram, she had LED ostium 95 and circumflex ostium 90. So whatever I had to do, either balloon or stent, I would have had to fix the circumflex too. Could not have left it for later. Maybe I could have changed it to a tap or something, but we would have changed it to a simpler technique.
Harish, in the DK crush that you did, you crushed the LED stent. Generally, we crushed as a sequence the circumflex stent, and even though you could do it otherwise, what were your thought process to crush the LED stent?
The reason being that one, that circumflex was a bigger vessel, and second, LED was previously infarcted, so she had re-infarcted. So I thought the circ is a bigger vessel which needs more protection. That's the reason I took the other route out.
Yeah, I think the circumflex was dominant vessel.
Yeah, that was the reason. Otherwise, normally I would do what you said.
I think we'll go to the second case, PCI in calcified vessels, my approach. I think Dr. Sahu is ready. Sir, are you ready?
Sir, I'm ready, madam. Is my screen visible?
Yes, sir.
Good evening, everybody. In fact, thank you, Deepak, for bringing me on the platform to discuss my experience on primary PCI and calcified vessels. I'm simply enthralled by the way Harish has put it, doing a rota, doing a lithotripsy, everything, even calcifying without even getting a slow flow. But my experience has been quite bitter when I have been doing rota or anything of this sort. But just quickly to share that any ACS may be presenting with a plaque rupture, a plaque erosion, or a calcified plaque. Now, my area of interest today is the calcified plaque. The calcified plaque may be an eruptive calcified nodule, a superficial calcium sheet, or a calcified protrusion. In fact, because I use a lot of imaging, so I would always prefer in a calcific lesion to use imaging and know what will be the strategy. And when we have a calcified nodule, we know that 4 to 7% of these have thrombi also and can lead to sudden cardiac death. And these plaques are usually eccentric with a variable stenosis. Now, we know this rule of 5 where we have to see what is the arc of the angle, what is thickness and what is length.
based on this, we know where to use the NC scoring balloon, cutting balloon, or an intravascular lithotripsy, or a rotablation, or orbital atherectomy. But believe me, whatever you use in such situations which have a lot of thrombus, slow flow is apt to occur. We have seen slow flow, no flow patients dying on table. So it is, as far as practical, try not to be very aggressive in this space because slow flow is really dangerous. While cracking the calcium also with the balloon, because with longitudinal stress, you might totally crack it and then the totally artery might get occluded and you might land up in problems. This was just a recent paper. The analysis was done about plaque erosion. You've seen that only around 10.8% of the STEMI cases have calcified plaques, and it is 14.78% of these non-STEMI patients which have a calcified plaque. So these patients do come, and we get a lot of octogenarians in our practice. The first one is 2 cases also. The first case is prepare the bed properly before stenting, and this is always the dictum while going for a calcium lesion. 78 years old female, diabetic, hypertensive. The first PCI was done to RCA in 2014 at Mumbai. She had come with her relatives on a pilgrimage to the temple town of Puri in 2020. Had severe chest pain at rest, and ECG showed infraval STEMI, and was shifted to my center with ongoing angina. I went for an emergency CG, and what you can see that everything, there is a stent in the right coronary, and there is a lesion. You can see something in the circ. First of all, I thought that this was possibly a thrombus that I was leading with. And this was just, this was done in 2021, this is March this year. And it was the COVID times. In fact, you can see there's something hazy over here, translucent area. And in fact, this was the LED was fairly okay. With a small plaque over here, which is significant. And the RCA, the stent was flowing. And when we tried to see what was happening in this thing, we thought first that possibly it could be calcium or could be a thrombus. The first thing that we did was that there was a distal lesion, so did a balloon angioplasty to the distal, the balloon crossed, but you can see the tram track calcium over here. So there was a discussion on whether to go for this thing, rota in this case, because the flow was good. But the patient was extremely frail looking, and was a very elderly patient. So first what I did was with a predilation with the NC balloon, and that with a very high pressure dilated it. And after the dilatation, I thought of debulking this with the cutting balloon. And this was the cutting balloon that was used to debulk it. And after the cutting balloon, I wanted to do an OCT, but the OCT wouldn't take this turn because, and moreover, this calcium, had to use a guidezilla to put the OCT ahead. And this was the OCT images, as you can see, at various levels. You can see the dense calcium that is there. There's some cuts that is done by the cutting balloon, and you can how much of calcium is here over here. So this was just basically a calcium nodule which is sitting over there, and serially at the sides you can see how much of calcium is there. And in fact, we got an idea that we were going to have a tough time. But then the question came at why not use another NC balloon and give a high pressure dilatation. In fact, that time it did yield. But then the stent wouldn't go. Again, I had to take the guidezilla, and with the guidezilla, the stent could easily float inside, and I gave a dilatation. And the stent could be deployed. And the stent after deployment, so it was not necessary that we had to use a rota. I was a little bit afraid to use a rota in this case because of the this thing that is a patient being too old and suspecting slow flow, and definitely the results was good. And did a post-OCT circ analysis, you can see the stent has been well opposed, and so, and this is the pre and the post results, where you can see that this calcific circ, which was the culprit, could be well dealt with. So it is exactly like what the coach had said, that failure to prepare is preparing to fail. So one should always try to prepare the bed very properly before taking the stent. The next case is that you need not wait for the preparation of the bed. Let the coronaries flow, as one of the panelists was speaking, that we did not wait because the patient might be too sick, and that is what is to be done.
This was quite a young man, 65-year-old male, non-diabetic, hypertensive, chronic smoker, has angina 4 hours duration since 7 a.m., ECG done at a local hospital, diagnosed with antiviral MI, MI stable, was given a DPT injection, low molecular heparin, and as they gave me a call, I asked them to rush to our hospital because it was hardly half an hour from our hospital that the patient had to come. This was the initial ECG that was done in their hospital. This was the ECG that was done in our hospital. And just as soon as they reached the emergency, there was incessant VT. He had to be defibrillated. CPR started, intubated, and rushed to the cath lab on CPR. And this is the CPR going on. And you can see that this patient has a cardiac arrest. We're trying to put in the IBP. This was a case done around 5 years back, in fact, and has been shown in some of the meetings also. And in fact, on this, after the IP is put, we could see the chunk of calcium over here. The temporary pacemaker is in there. This is intubated, and you can see how calcific this artery is. And we thought that we would lose the patient, and definitely we called relatives and started counseling. Nothing could be done. There was no rhythm. There was no pressures. CPR continued, and gradually, after around almost multiple episodes, VT, VF shocks, the patient started picking up. The blood pressure after repeated cardiac arrest started rising, and it was the first shot that we could take. It was a left main distal, which was extremely calcific, and the right coronary was normal. So in these cases, really somehow you have to open up the left main. You need not wait to prepare a good bed preparation. Go ahead and do whatever is best. And that is what we did. Took an NC balloon and on CPR, dilated it, put a stent somehow to see that the flow would be there. And this is what we got. We got a good flow. I didn't know what was exactly going on, but then also the patient still was in cardiac arrest with high inotropes, and slowly, in fact, hope started turning into life, and you could see that the patient specials started picking up, and took almost an hour of CPR. Finally, God had been kind, and you could see that the patient's rhythm started, and BP started picking up. And you're shifted from the cath lab with the patient's relatives and counsel that possibly the patient may not make it. There were steep doses of inotropes, temporary pacing, ventilation. The pupils are dilated because multiple ampoules of atropine had been given. The neurology consultation was done. Of course, the heart survived, but possibly he was brain dead. And they gave all the cetirizine, piracetam, phosphophenitoin, whatever drugs they could. But we're happy that by late evening, the patient started urinating and started moving his limbs by midnight. And I was awake in the morning and was trying to self-extubate. So I was really surprised because at around 4 a.m., the resident calls that sir, the patient is trying to self-extubate. And finally, what we saw, I took up the patient after 7 days, and I saw it was a very calcific lesion, and didn't in fact, there was a little bit raised, creatine. So just then I was, and I could see that the stent had not opposed, and there was good amount of calcium. And it is at this stage that what I did was that, again, did a post-dilatation, and then because the struts had come across the circumflex to the kissing balloon dilatation, and after the kissing balloon dilatation, again took and did IVUS, and I could see that the stent was very well opposed, well expanded, and in fact the patient had a good the LV started improving. There was hardly any MR, and this was the pre-discharge echo, and in fact he started doing very well. So always do not go for perfection in a primary, because we know that perfection is the enemy of good. So there may be times where we need not go for perfection. So what is my approach to primary angioplasty with calcified arteries? If the patient is hemorrhage unstable, I do intravascular imaging, debulk the strategy, do a stent, optimize on intravascular imaging. Now, selection of IVI depends on the patient's suitability. Whether the patient is old, then definitely it would be IVUS. If it is a young one, where I would like to know more of thrombus burden, it is an OCT. But this is mandated in my lab. In all ACS patients, I go for intravascular imaging if the patient is stable. Unstable AMI, I always tell open the artery fast, reconsider intravascular imaging once stable, and try to optimize after 5 to 6 days or 2 or 3 days as has been suggested. Thrombus suction is a must if there is high thrombus burden. watch for slow flow because this is the most notorious thing. And once there is slow flow, possibly you will lose your patient and you cannot do anything. Always remember that time is muscle, you have to work fast and never try to achieve perfection in the first shot because we know perfection is the enemy of good. Thank you very much for the patience.
Thank you, Dr. So he has opened the case for discussion because he has raised an interesting point whether we could wait. So do we wait, restore the flow of the artery and then go for stenting later, or do as you do, stent the artery and then stent the artery and then what do you say, optimize it later? So the panel doctor can answer that.
In general, when somebody comes with STEMI, the moment there is STEMI 2 flow, they become asymptomatic and many times ECG also will start regressing. The first case there was, I agree that there was a very calcific, very tight stenosis at the proximal circumflex, but still the patient was symptomatic and I mean, you were forced to take up the patient at night itself, right?
Yes.
So, comments from other panelists.
Excellently done, Dr. Prashant, especially your teamwork. Actually, the teamwork is the key. Your continued CPR almost 1 year, 1 hour. I'm sorry, it's very good. And then keep the hope alive. Adequate revascularization, and we also had patients who had cerebral hypoxia, hypoxic encephalopathy, had seizures in the night, hypoxic seizures. The next day morning they wake up. So it's always worth trying when the patient comes an acute MI cardiac arrest. Teamwork is the key, and a reasonably good revascularization will do the trick.
Dr. Sahu, your presentation was elegant and you brought out some of the important characteristics of patients with calcified plaque and how to treat those patients when fought with STEMI and primary PCI. So as Harish had shown on the previous presentation, road ablation is one of the choices, but now you have an IVL. So in the present era, if IVL is available on your shelf, that certainly becomes a significant boon because it does not cause any distal particulation and there is no slow flow because of the calcific vessel being dilated. Otherwise, with repeated balloon dilatations that you may have to use to optimize the bed preparation, it often leads to slow flow, no flow, and the myocardium would be left dysfunctional. So that's something that we are progressively improving upon. I had a patient who was not too old, but most of the patients who are either diabetic or having CKD in various stages of CKD, they are prone for having calcified disease and also elderly. So we need to anticipate that when such patients being taken up, we would have to encounter patients with calcifications. But recently I had a patient who was 43 years, who had a previous PCI for an inferior wall STEMI about 6 years back, and now he came with an anterior wall MI with an LAD. The balloon did not dilate, so once you know that the pre-dilatation balloon does not give up, is likely to be having, and if you do a stent boost along with the NC balloon, you would see a sheet of calcium even in the absence of imaging. So and then I had to do an IVL, and it did give a beautiful results, and I could implant in a tight lesion, approximately a 4.5 mm. After the IVL, I could do IVUS imaging and then choose the stent size. So it offers another choice now in calcified vessels with primary PCI, where ablations may be sparingly chosen.
Sir, if the artery is flowing, would you wait till the next day to optimize your procedure better, Dr. Sahu? Would you wait?
See, what I normally do, I just have to achieve a TIMI-3 flow. If I achieve a TIMI-3 flow and I think my job is done, then I'd like to bring the patient the next day and if required stent it. But if it's a calcified lesion, I just might underdilate and come out, just put a stent and then wait for at least 6 to 7 days or after 2 to 3 days, take it back, do an imaging and then do the post-dilated and optimize the stent. don't, as I told you, don't try to achieve perfection in one go. If you try to achieve perfection in one go, then you will definitely land up in problem. That is what I have seen. And using too many devices also, I am against it. We have to achieve a TIMI-3 flow or a TIMI-2 plus and somehow and save the patient, see the hemodynamics are maintained. That is the primary aim of a primary angioplasty. It is not that the cosmetic that is most important. It is how we save the patient that is most important.
Supposing you don't have IVL on board, would you try an OPN and see? And
yes.
take an undersized balloon, go to high pressures.
Problem is that if you go to very high pressure, slow flow is there, we have seen. If there is a calcific lesion with good amount of thrombus, if you have not cleared the thrombus, you just go on dilating, again it is a sort of a cyclical process and you go on to having slow flow. And it's very difficult if the patient goes into slow flow and it goes into cardiogenic shock, it is very difficult to bail it out at times. Because all the peripheral arteries are all clogged and everything is clogged and there is hardly any blush that you get in the myocardium.
Now it's the last case with CPR, it is fully said it's a teamwork. But however, I will like to know this good old question, whether you went with an IABP first and perfusing the coronary artery. So the general thought is first to open up, then go on with IABP, because this patient did not have anything to start with. So don't we think that first you perfuse the coronary, then you think of putting on maybe simultaneously here whatever was going on, because with IABP first. This is a general question which everyone has a thought process in a different way. That's the reason why this question is asked. No.
See, what I personally feel is that get your IABP first before you start attempting to intervene. Because once you take the first shot, it might be the last shot for the patient. I always insist that you're the one person, your assistant is taking the puncture on the other side and going on with the IBP while you are getting ready to take ahead with the shot. But the patient was literally an assistole. We didn't venture also to take a shot, because sometimes the dye hangs like anything and you cannot clear it out. So it is better that the IAP is inside, your temporary pacemaker is inside, the patient is intubated, and then you try. In fact, I kept on doing CPR to see at least some rhythm. And without a rhythm, it is foolishness to push contrast into the coronaries. That is what I felt. So, but anyway, it was we are lucky that day. In fact, we have 2 or 3 cases which did come out. It is not that, but only thing is don't give up. That's the whole thing. Maybe you were the last hope for the patient.
I totally agree with you, sir, Dr. Sahu, but case to case it may differ.
Yes.
At times you have seen in some patients, the moment you pass the wire across the left main, the rhythm comes.
Exactly, I agree.
So we can always kind of keep flexible. But in our institute, we do not give so much importance to IABP. Somehow our routine is to put TPA and straight away look for the corners and try to open up. Even a TIMI-1 flow is fine. Then you can think about IABP and other things. So our priority has been to bring in some flow and know the anatomy and mentally prepare what we are going to do or what we are going to expect. Then do all other supportives. But it was a very excellent case, very encouraging case.
Dr. Kanan, I would like to differ here a little bit. I would like to see there is no hemodynamics, no BP, no pulse. So how can I do an angio in there? That means a dead patient almost.
Yeah, understood, sir. But IABP works only when there is some BP, isn't it, sir?
Yes, it's some BP. But the CPR is possibly helping. That's the whole thing. But it is very difficult to know actually. Each patient is a different entity. That's it.
Understand.
I think if you don't have a stable rhythm and patient does not have a hemodynamics, the MCS support is very prominent and that has to be chosen. And particularly if there is no rhythm and VF is continuing, the temporary is not able to capture, ECMO, VA ECMO is the way to go ahead. And then there is a saying that you feed the body and save the heart later, because it's important to maintain the perfusion for the rest of the body as well. And then you can work on the heart. So it gives you some time to establish a non-linear flow with the ECMO.
So we are unlucky. We don't have an ECMO in our centers.
So just a quick
Thank you, sir.
quick
Thank
question.
you, everyone. It's time to go for the third case. Can we invite Dr. Karthik to present his case?
Are you able to see my screen and hear me?
Please go ahead. It's very clear.
Yeah. Thanks, Dr. Kannan and Dr. Sujata. And I thank Deepak for inviting me for this wonderful meeting. So I've been asked to talk on primary PCI in bifurcation, my approach. Bifurcation lesions in ACS are encountered in 10% of cases in our daily practice. The inherent difficulty of bifurcation stenting stems from the fact that after we implant the main branch stent, this leads to acute impairment of blood flow in the side branch, especially in ACS because of the clot migration. The true clinical relevance of side branch is notoriously difficult to standardize. And apart from acute occlusion of side branch, bifurcation stenting is also associated with increased incidence of long-term MACE, including stent thrombosis. It carries poor success rate and worse long-term outcome if not performed properly. So these are the factors to be considered about the side branch relevance. The diameter of the side branch, the length of the vessel, angle between the main branch and the side branch, the amount of myocardium subtended by the side branch, myocardial viability, collateralizing vessels, ischemic symptoms and comorbidities, and left ventricular ejection fraction. So my approach in ACS for bifurcation lesion would be, I would just look at the side branch, whether it needs to be preserved, whether it's a big branch or a small branch, whether we can ignore it. If it is a small branch and we can ignore it, concentrate on the main vessel, do a PCA for the main vessel. If it's a big branch and you need to preserve it, then look at the likelihood of side branch occlusion. And if the likelihood is very high, then go for straight away two stent technique. If the likelihood is low, that is it is coming at a right angle and there's not much of osteal disease, then I would do a provisional stenting and I would wire the side branch and do a crossover stent. Then I would look at the side branch, whether it's compromised or it's flowing. If there's no compromise, then I would stop at that point. If there is compromise, then I would do a balloon angioplasty. And if the balloon angioplasty is able to successfully restore the flow and we get an acceptable result, I would stop there. If the balloon angioplasty fails and there's a compromise of the side branch, I would then look at the angulation of the side branch and convert that into a two stent technique. If the angle is 70 to 90 degrees, then I would do a tap. If the angle is less than 70, I would do a reverse crush or internal crush or culotte. And in the case I decide to do a two stent technique, then we look at the side branch angulation. If it is 70 to 90 degrees, I would do a T stent or a tap. And if the angle is less than 70, then I would do a DK crush or a culotte. So this is the general strategy what I follow in case of a bifurcation stenting in ACS. The provisional side branch strategy is the default strategy currently recommended. Its importance is given to the main branch stenting and optimizing the result. Side branch intervention is done if there is dissection, flow compromise, or if there's more than 75% stenosis after stenting the main branch. So on this background, I'll present about 2-3 cases which which alludes to whatever I have spoken now. This first case is the 63-year-old gentleman presented with engine of exhaustion since 20 days. He's a doctor and he had undergone a treadmill test 1 week back elsewhere. It was strongly positive and he was advised an urgent angiogram. He did ignore it. And the previous day of the visit to the hospital, he had rest pain for 30 minutes. So he had a history of long-standing diabetes and hypertension, smoker. He had a mild troponin leak and we diagnosed as NSTEMI. Then we took him for an angiogram. You can see there's a very critical LAD osteal lesion. Distal left main, there's a critical lesion. Circumflex ostium somewhat seems to be a little bit hazy, but I think relatively free from disease. And it's a very small circumflex artery. And RCA was quite dominant. So this is a Medina 110. So what we did, we gave him the option of both bypass as well as angioplasty, but he wanted us to go out with the angioplasty. So what we did is we decided to do a crossover stenting and look for the side branch. If there's any compromise, we are prepared to convert it into a tap or a T. And so what we did is we took a 3.5 into 10 angiosculpt and prepared the bed nicely at 12 atmospheres, opened it very nicely. And this was a 4 millimeter left main. So I took a 4 into 28 DS and deployed the stent. And after the deployment, the side branch looked pretty much okay. The ostium was pretty much clean. There was no compromise. There's no dissection, no flow compromise. So I went and did a pot after the post dilatation. The pot with the 3.5 and 8 NC. And after the pot, you can see there is some haziness, and I felt it as there was some compromise of side branch. So what I decided is I opened the side branch and put in a 2.5 to 10 dB in the circumflex and 4 into 10 NC in the LAD, and did a kissing. Then after the kissing, it looked good, and I left it at that. I didn't put any stent in the circumflex. The second case is a 60-year-old male presented with acute coronary syndrome, acute interval MI, no comorbids. He was taken up for primary angioplasty, and the left coronary shoot showed critical lesion in the distal mid LAD involving the bifurcation with D1. It was a Medina 111. Even the proximal circumflex had a 70 to 80% narrowing with some haziness. So here we decided to go ahead because if you look at this angio, the diagonal is much bigger than the distal LAD. So we had to preserve this branch. So we decided to do an upfront two stent strategy, and we wanted to put the main stent into the diagonal. So we decided to do a DK crush. I pre-dilated with a 2.5 and 15 balloon, the proximal LAD, and the distal I dilated with a 2 into 12 balloon at 10 atmospheres. Then we implanted a 2.25 to 23 Zines V stent in the mid LAD and crushed it with a 2.5 into 10 NC balloon. Then we did a first kiss with the stent balloon LAD and 2.5 and 10 in NC in the diagonal. Then I took a 2.75 28 DS in LAD across the first stent into the diagonal, deployed it. There's some under expansion. You can see that. So poured it with a 2.75 into 10 NC, and then did the final kiss with a 2.75 10 in diagonal and 2.5 in LAD, and pot with a 3 into 10 NC. So this was the final result. So this is a third case, the last one, a 41-year-old morbidly obese patient presented with chest pain of 1 day duration, non-diabetic, non-hypertensive. He has a strong family history, mother had an MI. ECG showed prominent T waves in antileads, troponin leak was there, NSTEMI. I took him for a angiogram, and you can see there is a clot extending from the left main ostium to the LAD ostium. It was more of a plaque rupture in the LAD ostium, which had caused the clot to form. And in this view, you can see it there. So what we did is right coronary was normal. So because this fellow was a young guy, we wanted to image and see what's going on there. So we did a OCT run after anticoagulating him for 48 hours and brought him back and did an OCT run. You can see there's a calcific nodule coming up there. You can see, calcific nodule there. And as we go proximally, there's a thrombus, some erosions. And as you come to the circumflex LAD ostium, there's a plaque rupture, clot, and in the left main, you can see a thin cap fibrous atheroма. So here you can see the distal landing zone was 4.8, the calcific nodule, then the thrombus, then the ostium had a plaque rupture, and in the left main, we saw a lipid-rich plaque with a thin cap fibrous atheroma. I think Dr. Kevin's talk was very interesting. Whenever you see a thin cap fibrous atheroma with lipid-rich plaque, these are the lesions which are supposed to, if you don't treat them, they're going to have a future event. That too in the left main, it's not good. So we decided to go ahead and stent this particular lesion. So we used a 4 into 23 DES, and I did a direct stenting because I didn't find much of fibrous tissue or calcium in the lesion. So that was stent nicely expanded, and we had measured with the OCT, it was 4.8 and 5.2 in the left main. So I took a 5 NC and post-dilated and did a pot with the 5 NC, and you can see there, and nicely opened up vessel, and there's no side branch compromise whatsoever. But now we had the advantage of doing the OCT, so we put in the catheter and looked for the expansion, and particularly we were interested in looking at the bifurcation where the circumflex takes off from the left main. So the OCT run showed extremely good expansion, absolutely no malapposition. And the interesting part was the circumflex bifurcation. If you look at it, there's only one stud across, absolutely there's no crowding of the metal here. And even there was a small diagonal which came that also had only one stud here. And we decided not to do anything. And on the 3D reconstruction, it looked excellent. There's just one stud across. We didn't want to distort the main branch stent, so we left it at that. Even the fly-through picture also confirmed that. You can see here the diagonal, only one stent across. As you go down, you can even see the circumflex. There's just one stent across, and stent nicely opposed. We thought we'll stop here, and we accepted the result, and he's doing well. So, so the take-home message will be bifurcation stenting in AMI is not uncommon. Provisional stenting must be the default strategy, as a single stent is shown to be superior to two stents. I didn't quote any studies because Deepak said we'll keep it simple and more of cases and more of discussion. I didn't bring in the theory. There are a lot of trials which have shown single stent, crossover stent is much superior to two stents. When the side branch is important to preserve, upfront two stent strategy should be planned, as I showed you in the second case. A DK crush may be a good option. I'm very comfortable with DK crush. I think whatever the strategy you are comfortable, I think you should do it. And while doing single stent, provisional stenting, TAP or T stent may be a good option as a bailout strategy in case of side branch compromise. Imaging will help in bifurcation stenting to improve the outcome and reduce the MACE. Thank you for your kind attention.
Thank you, sir. Thank you for the nice case examples. Of course, the message is very clear. Try to keep it as simple as possible. Just one comment on the second case, where the diagonal branch was much larger than the main LED. But however small the main LED looks like, still it is physiologically more significant because it's supplying the septum, which is common to both right ventricle and left ventricle. That's why many times you see even distal LED occlusion will have more symptoms than a large diagonal being occluded. But there you chose to stent from the main LED to diagonal because the diagonal branch was larger, and that allowed you to use a larger stent because the main LED was the smallest stent. So that should be the understanding of the decision making there. So all three cases were very well nicely demonstrated. Thank you. So comments from other panelists, please.
I also agree with Dr. Vasudevan that the single stent approach and even with the EBC main results, where even in 011 and 11 lesions, they have preferred the provisional stenting strategy even in the left mains, and used a stent, second stent only in almost 20% of their cases. So this gives us hope, and especially in acute MI situation where you are stuck at ungodly times, I think single stent strategy would really be the way forward. Any other comments? Dr. Suresh Kumar.
I think all the three previous speakers, they didn't mention the intracoronary pharmacotherapy, whatever they used to prevent the no reflow, though they did mention about no reflow. Probably they knew that Dr. Jabir is there waiting to explain in detail. But otherwise, that is equally important. And rather than addressing only the anatomy alone, that's also equally important.
Yes, Dr.
I didn't mention because Jabir has got a whole talk on that. However, I would like to mention we use intracoronary sodium nitroprusside. It's wonderful. It gives a very good flow, and we use tons of it, almost like 1,000 to 2,000 micrograms of intracoronary sodium nitroprusside. With each balloon exchange, with each post-dilatation, pre-dilatation, we give 50 to 100 micrograms of sodium nitroprusside. That has worked very well for us, and I think it prevents no reflow better than most of the other drugs available. Anyway, we're going to hear more from Dr. Jabir.
Yes, sir.
Karthik, one question to you. Karthik, you mentioned regarding the provisional strategy in acute MI bifurcation would always be preferable in any sort of situation, even if it's a chronic stable angina, you would always try doing that. Now coming to the choice of decision regarding whether it has to be a DK crush or whether it has to be a culotte strategy or a tap technique. Now, would you would you prefer going in for a simpler technique for an LED D1 compared to a left main bifurcation? Let's say we know that when you have a left main bifurcation, a DK crush would be preferable over the other techniques. And when it comes to a large LED D1, would you try to go in for a more simpler strategy just because of the reason you have a lot of clot burden over there, multiple balloon dilatation, the chances of slow flow would be better if you go for a simpler strategy like a tap technique compared to a DK crush strategy wherein you have multiple balloon dilatation. So would you decide that way based on LED D1 and the left main? Would your strategy be different?
Deepak, that's a fantastic question. Actually, the decision would be based on the angle of the side branch. If the angle is favorable, if it's 90 degrees, then you would go for a T or a tap. If it is less than 70, then it will be difficult to do a tap or a T. You by default will be going in for a DK crash or a culotte. And I agree with you. In case of an acute MI, it's slightly different. You have to be careful about the clot, but I think that's more dictated by the angle rather than the other anatomy.
So regarding your second case, Karthik, it was a wonderfully done case, the LED D1 bifurcation DK crash. But what about the panelists sitting here? I thought that the diagonal ostium did not have huge plaque burden. So a simpler strategy is tending from LED to LED and then see how the ostium looks like, so that it will be a more simpler technique. Rather, I'm not questioning what you have done, but what about the others' opinion? What would the others think about this particular bifurcation LED D1?
Yeah, that's what I brought in, because
that was not significant.
Rather than the size of the vessel,
Karthik, who can decide on such operator.
Hello?
Yeah.
Yeah, Deepak, that was a Medina 111. I agree the involvement of the diagonal was less compared to the main vessel, but definitely it was involved. It was a Medina 111. And if you it is a very small LED. If you look at it, I dilated with a 2 millimeter balloon and above 2.5, whereas it was the 2.75 on the diagonal. And putting a small stent across, and in case there is a compromise, again switching over to another strategy, it would be difficult, And so that's the reason I thought we have to preserve that. That's a huge branch. If you see the diagonal, it's bigger than the LED. The distal LED looks diffusely diseased and it's very small. So that is the reason I decided upfront to two stent strategy and plan to do a DK crush.
Sir, I thought we could stent into the diagonal, consider the LED as the side branch, and only if it is compromised, do the diagonal. Stick to a simple single stent strategy as far as possible.
Yeah, point well taken. But in that particular case, I decided to do that way. I think the result was okay, and the patient is doing fine. Now it's almost around 5 years now, more than 5 years. He's doing fine.
I think it is the decision of the operator at that particular point of time. He only can decide on which is the best strategy. I just wanted to know from Deepak, anyway, Deepak, you are also interested in doing imaging. So in such situations, imaging seems to help. It can tell us what exactly is the side branch issue and what is the chance of the side branch closure. And even after a provisional stenting, we can have a look at the side branch ostium and then decide whether we should go ahead with the two stent strategy or can leave the side branch ostium if it is fine and there are no struts or connectors across the side branch ostium. So I think that these are situations where imaging makes a difference.
Jabir, very well mentioned regarding imaging also. In acute myocardial infarction, we would also try to mostly avoid imaging primarily because a patient is sick. You wouldn't want to increase the amount of contrast being injected into the vessel. So in this particular, it looks more like a distal half of the LED that was involved. Looks as if the patient is hemodynamically stable. So once you achieve good TIMI3 flow into LED as well as via the LED diagonal, try to dilate with 2 mm balloons, and then it's worthwhile seeing having a look at the diagonal ostium to decide on what would be the strategy like. As you mentioned, I would definitely agree that Karthik, the operator should be the best person to decide on what should be the strategy like.
I also fully agree with you. In the primary PCA setting, it is better to avoid all complex procedures, but there are situations where, as in this case, the thrombus burden is low, so imaging may be feasible, or not all cases, not for all.
Jabir, yeah, I agree with you. See, in the proximal positions, it's easy to image. Like left main, proximal LAD, proximal circumflex. In the distal part, once you put the OCT catheter, the dye won't clear. If you inject a dye, the OCT catheter will be occupying and there will be some thrombus and dye won't clear. You won't get a good image. Proximal part, it's good. I showed you the third case. That's the reason I put in imaging case, which helped us to decide whether we should stent the LAD or open the studs with a balloon at least, so that in future there is no any intervention is required. So because you just saw one connector, one stud across, we didn't disturb the main stent and we left it that way. I think imaging definitely helps you in deciding on the side branch stenting.
No doubt, Karthik, fully agree with you. I just wanted to bring in the discussion of an imaging in a bifurcation, even if it is a primary PCA. There are
absolutely.
Where you may be able to do it, not in all cases. Fully agree.
Yeah, there are selected cases you should do, I think.
Now, once we have done partial revascularization, the patient is stable, we can take time to do the revascularization. Being a primary should not be an excuse for not doing revascularization. So thank you everyone. Can we go to Dr. Javed for his talk, please?
My slides visible?
Yes, sir. Please go ahead.
One minute. I think it is okay. Is it visible, Kannan?
Sir, it's perfectly fine, sir.
Oh, thank you. Good evening to all, and it's a great pleasure to be a part of this fantastic meeting, and I thank Deepak for this great opportunity. I'll be talking on slow flow in primary PCI. What are the tips to prevent it? Previously also, Kannan was also mentioning regarding pharmacological therapy and the intracoronary pharmacological drugs which are going to help in this situation. So slow flow or a no reflow, both these terminologies are used interchangeably. This basically means an inadequate myocardial perfusion in a given coronary segment in the absence of a angiographically visible mechanical obstruction. So this can lead on to, as we have seen in different these pictures or the frames over here, this may be a truly difficult situation, and this can end up in myocardial damage, a poor infarct healing, adverse LV remodeling, heart failure, and death. And the two most important pathophysiological mechanisms involved are microembolization, the emboli from the plaque material, as well as the thrombus, fragmented thrombi, and also the local release of the vasoconstrictors. And in fact, this is a puzzle with many pieces. It is not a simple thing, and there is no simple, straightforward solution of all cases of no reflow. The Melbourne Interventional Group Registry data, a little older data, 2005 to 2013, older data, there are a lot of problems of older data. They were not using an aggressive antiplatelet therapy at that time. These powerful antiplatelet agents like ticagrelor or prasugrel were not available at that time. So there is one limitation. So this is 20,671 patients of normal reflow compared with around 743 patients with a transient no reflow and 191 patients with a persistent no reflow. These are correlated with the event rate, not only short term, but also the long term. The MACE rate in hospital, 30-day and 1 year. There's a significant difference between the normal flow and a persistent no reflow. Persistent no reflow, 15.3% MACE in hospital, 6.4% MACE at 1 year. And this 15.3% in hospital MACE compared against 3.4% when there is no reflow. So it's almost 5 times increase in the MACE in the hospital. The long term also, the mortality, long-term mortality of 31, 5.2 years. A persistent no reflow, 1/3 mortality. When the normal reflow, it is 14%. So in the long run, at least double the number of normal flow patients are likely to die when they had a persistent no reflow. So in hospital, 30-day and 1-year-old cause mortality were all higher in the persistent no reflow situation. So no reflow has got a real and a bad impact on the outcome. So poor outcome correlated with the no reflow. Why there is a no reflow? A coronary occlusion, prolonged ischemia, platelet and endothelial activation, vasoconstriction, inflammatory response, myocardial edema, oxygen-derived free radical injury, and calcium overload. All these things together can lead on to a microvascular damage. Along with, when we do a PCI, there is distal embolization, there is the plaque material fragments, the thrombus get fragmented, and both these things can get migrated distally, resulting in a no reflow with adverse cardiac remodeling. And what are the potential targets for intervention? You can reduce the ischemic time, that's important. Platelet inhibitors, potent platelet inhibitors, vasodilators, anti-inflammatory agents, anti-thrombotic agents, thrombectomy or thrombus aspiration, and of course, heart failure management. So when do we expect a slow flow in a percutaneous primary PCI? So that's the most important thing. The operator can predict this is a group of patients, or this particular patient is likely to develop a no flow. So we have to take every precaution possible to prevent a no flow. You can see the first picture is a RCA, the second is a left main thrombus, the third is a SVG graft producing an acute MI occlusion, producing an acute MI. So all these are situations, and the finally is rota, which is unlikely to, we do a rota in the presence of a primary angioplasty. So ACS late presentation, large thrombus burden, a venous bypass graft occlusion, and acute MI, which is from a primary PCI, rotational atherectomy, and patients in cardiogenic shock. So these are the group of patients who are likely to develop a slow flow. This is a 68 years old male, diabetic, anterior wall STEMI. Symptom onset to emergency room time is 16 hours, and you can see the LAD, which is totally occluded, and the flow itself says that it's only a TIMI1 flow itself says that it's extremely likely if we go for an intervention straight away, there is likelihood of a significant slow flow or a no reflow. In fact, if you look at the angiogram, many of us would say that the myocardium is unlikely benefited by doing a percutaneous coronary intervention. The myocardium may be permanently damaged in this patient. So we can predict it from the angiogram itself. So what are the drugs that we can use? This data on 13 studies, meta-analysis, clinical benefit of adenosine as an adjunct to reperfusion in ST elevation myocardial infarction patients, updated meta-analysis, a better myocardial blush grade with the adenosine, better TIMI3 flow rate with the adenosine. So no flow phenomena was less when adenosine was used, but here multiple studies, different dosage schedules of adenosine. The dosage varies from 120 microgram bolus followed by 1 milligram IV intracoronary adenosine to 4 milligram intracoronary adenosine, or even continuous infusion of adenosine 70 microgram per kilogram body weight per minute for hours. So varying doses. But what they found was, this is important, the incidence of coronary no reflow was reduced. A better TIMI flow 3 rate post reperfusion with the use of adenosine. And after looking at all these data, what I feel is that for the proper dosage, we don't know, nobody knows what is the proper dose, but this is the average dose. The median dose, if you look at it, is 2 to 4 milligram intracoronary. What adenosine we use is perhaps 500 microgram, 1 milligram. So actual dose of adenosine is pretty high. So the short-term effect of verapamil on coronary no reflow associated percutaneous coronary intervention in patients with acute coronary syndrome. This is a systematic review and the meta-analysis. They found that better TIMI perfusion grade when the verapamil was used. Intracoronary verapamil associated with a better coronary TIMI reperfusion grade. So what they found is that intracoronary verapamil injection was beneficial in preventing no reflow, slow flow, reducing the corrected TIMI frame count, improving the TIMI myocardial perfusion grade, and lowering wall motion abnormality. It's also likely to reduce a 2-month MACE in ACS patients post PCI. Only problem right now, we don't have intravenous verapamil. So we are all into other drugs. Intravenous administration of nicorandil immediately before percutaneous coronary intervention can prevent the slow coronary flow phenomenon. Here also the nicorandil administered was 6 milligram of nicorandil dissolved in 20 ml of 0.9% saline in the nicorandil group and 20 ml of 0.9% saline in the control group. So 6 milligram, not a small dose, it is 6 milligram in 20 ml of normal saline. What they found is that there's a significant reduction in the no reflow. The no reflow was seen in ACS in 4.3% of patients who were put on the nicorandil versus 26.2% of the patients who were not given nicorandil. So a significant difference, it's almost 6 times. So a 6 times reduction, 6-fold reduction in the occurrence of no reflow. And there was a better myocardial perfusion grade also. So this simple procedure prevented the slow coronary flow phenomena, not only in patients with ACS, but also in patients with non-ACS without any adverse event. High-intensity statin preloading on kidney flow in patients presenting with ST elevation MI undergoing primary percutaneous coronary intervention. A better myocardial blush grade, better kidney flow in those patients who are given each milligram of atorvastatin prior to the PCI. High-intensity statin loading before primary PCI resulted in improved post-procedural kidney flow, myocardial blush grade, complete ST segment resolution, and ended up in a better preservation of the cardiac function, better ejection fraction. What about the thrombus aspiration during primary percutaneous coronary intervention? We were all thrilled by seeing this data of the TOPAZ trial, a significant benefit in terms of myocardial blush grade with the thrombus aspiration, a significant benefit in terms of resolution of ST segment elevation, a less persistent ST elevation with the use of thrombus aspiration. So thrombus aspiration is applicable in a large majority of patients with MI with ST elevation, and it results in better reperfusion and clinical outcomes than conventional PCI. Irrespective of the clinical and angiographic characteristics at baseline, a single center data. People started using thrombus aspiration left and right. Then came the other trials where this result was not replicated. The total, the taste, and there is an individual patient meta-analysis from the thrombectomy trial is collaboration. Finally, so these two trials, the total trial and the taste, they could not find any benefit with the routine use of thrombus aspiration. So I believe in what these contemporary reviews editorial says. Thrombus aspiration for ST elevation MI in the modern era is still an issue of debate. So this is the total investigator, the total trial. They could not find any benefit in terms of a TIMI3 flow, no difference between the two groups, and similar no reflow rates. In the taste, the no reflow rates were not available with the paper. But the rate of distal embolization are reduced with thrombectomy. So this benefit was there, reduction in the distal embolization, but there was no benefit in terms of outcome. So as a believer of data, this patient came in, acute incidental myocardial infarction, significant thrombus burden. With the data, there is no need for a routine thrombus aspiration. I straight away wired, balloon dilated, difficult, so put 2 wires, put in a long stent, dilated, and ended up in total lack of flow beyond the stent. Multiple runs of thrombus extraction, sodium nitroprusside, verapamil, nicorandil through the aspiration catheter. And we were lucky that the patient's hemodynamics permitted all the vasodilators because the left system was absolutely normal, and finally with all the pharmacological agent inside, after a long duration struggle, the patient improved. He could finally be shifted out of the cath lab with something close to a TIMI3 flow. Can we use an intracoronary adrenaline in such situation? I don't know. I have heard of my colleagues as well as other people during many discussions saying that intracoronary adrenaline may be useful if there is a severe coronary reflow, but not for prevention. And the meta-analysis, the thrombectomy trial is collaboration. They say one thing, in the high thrombus burden group, there is a trend towards reduced cardiovascular death. But there is an increased scope for transient ischemic attack. So we need more data, and it is extremely unlikely that more data will come. So now it all depends upon our experience and our clinical judgment. So routine aspiration may not be required, but in a high thrombus burden, in a delayed presentation, These patients are likely to go in for a slow flow or a no reflow. So I prefer to do a thrombus aspiration prior to stenting to reduce the incidence of a no reflow in this situation. A 55-year-old male with an inferior wall STEMI taken up for a primary PCI, and you can see the RCA, pretty bad RCA, really difficult a vessel for a primary angioplasty. We put two stents of 3 into 48 and 3.5 into 38 drug-eluting stents with overlap. Didn't post-dilate. I was afraid of the slow flow. We didn't go for any other complex bifurcation stenting, though I have put a stent across the bifurcation into the PDA. There was some pinch of a pretty large PLB. Didn't go for a real bifurcation stenting. Plenty of trucks, intracoronary sodium nitroprusside prior to the stent and after stenting, and we have given intracoronary adenosine also. Hemodynamically stable. This patient had a LAD disease also. So this patient was put on intravenous tirofiban after intracoronary tirofiban bolus dose for 24 hours infusion, put on ticagrelor and aspirin, and he was taken up again on the third day for an interval procedure. Again, LAD, there is a bifurcation. We didn't go for a bifurcation, a single stent crossover stenting without touching the diagonal. Then when we looked at the RCA, we can see the RCA stent is really under expanded. So we went ahead with a 3.5 millimeter balloon post dilatation, a 4 millimeter balloon post dilatation, and a decent result. So now in a safe environment, a better and a safe environment, it is a little more safer to do the post dilatation. Had I done the post dilatation 3 days back, I would have closed the entire flow. Now you can see the PDA is flowing well, the PLB is also flowing well. There may not be any need for a bifurcation stenting to the PLB. In a PCI, primary PCI, to prevent a slow flow or a no reflow, we may avoid long stents if possible. Always it is not possible. If the lesion is of long lesion like that, what has happened in this RC, there is no way out. You have to put a long stent. Direct stenting may be preferred rather than multiple balloon dilatation, which can increase the chance of no reflow. Avoid post dilatation, not possible many a times, and consider it at a more safe time, a safer period. After 2 days or 3 days, patient is stable and all the antiplatelet agents and the other drugs are on board, and you can take it in a safer environment. A slow inflation and deflation, there is no data, but it's by experience, a slow inflation and deflation may help in reducing the slow flow. Pre-treatment with vasodilators, there is data. Sodium nitroprusside, calcium channel blockers, verapamil, nitroglyceride, we don't have much data. Adenosine, there is data. Nicorandil, there is definitely data. And powerful antiplatelet agents like a ticagrelor or a prasugrel, and avoid complex stenting techniques like a complex bifurcation stenting. Always it is better to be quite simple, as Dr. Sahu was mentioning in his case. No beautification. Try to obtain the TIMI3 flow, get out. If a restenosis comes, we can handle it later on, and it's not life-threatening many a times. Here, the patient should be alive. TIMI3 flow, take the patient out of the cath lab, put on drugs, let him come back to the life, and then later on, if some problems, we can, there are a lot of options. First thing is to keep him alive. So an anterior wall STEMI, left main equivalent, primary PTCA, we thought there is no point in going for a very complex, you can see complex bifurcation stenting, rare situations when we go opt for a V stenting. We did the V stenting, patient is still under follow-up. You can see even after V stenting, there was some amount of slow flow. Had we gone for a complex stenting, it would have been a difficult problem. So avoid complex stenting in the presence of significant thrombus burden, or when you judge that the chance of a slow flow is quite high. This is the data published in Indian Heart Journal, that is from Trivandrum Medical College. The predictors of no reflow during primary angioplasty for acute myocardial infarction, they found 1/4 of the patient, 181 patients, 1/4 of the patient developed a slow flow or a no reflow. And the factors are elderly, more than 60, prolonged ischemic time, delayed presentation after 6 hours, initial TIMI flow is 0/1, initial TIMI myocardial perfusion grade of 0/1, heavy thrombus burden, high thrombus burden, grade 4 or grade 5, a longer lesion, that means the longest stent you require, target lesion length more than 20 millimeter, a TIMI class 3 or 4, and overlap stenting, so by or a long stents. And after multiple regression, multiple regression, the independent predictors were longer reperfusion time of more than 6 hours, a long target lesion, a low initial kidney flow, and they have concluded it's important to minimize trauma to the vessel. So multiple balloon dilatation should be avoided. Avoid repetitive balloon dilatation. Use a direct stenting and use the shortest stent possible. And use, I must say, use pharmacological agents if you feel that there is a high chance of slow flow or no reflow. So what's my approach to reduce slow flow? A pre-treatment with a high-intensity statin, powerful dual antiplatelet therapy, glycoprotein 2b3 antagonist if significant thrombus burden, thrombus aspiration if high thrombus burden, pre-treatment with intracoronary adenosine, nitroglycerin or sodium nitroprusside, short stents, direct stenting if possible, and may avoid post-dilatation in selected patients and avoid complex movement. So after all these things, I must say no reflow is still a next challenge in the treatment of ST elevation acute myocardial infarction. Despite all these things, unpredicted slow flow, persistent slow flow, loss of myocardium, and irreversible myocardial damage all occurs, which we all see day by day. So what is the management, or what are the methods to prevent a slow flow? It's all what we have gained from asking, acquiring, appraising, applying, analyzing, adjusting with the evidence, science, and experience. And all these things combined together, we have the current practice of prevention of slow flow. That's all what we can say. For all what we practice, there is no evidence, but it's by the experience. There are some things with evidence and science, something is out of experience, the clinician, which we are acquiring or acquiring from others, acquiring from peers, uprising from our superiors. Then we apprise and apply and we practice. No doubt, it's extremely important to prevent a slow flow. And these are all what are the things available right now. For all these things, we don't have evidence. For some things, we have evidence. Some it's all experience the clinician. Thank you so much for your patient listening.
So thank you, Dr. Jabe. It was a kind of comprehensive discussion. Regarding your last slide, your experience counts. I remember one comment. Your approach to the next patient depends on your experience on the previous patient of the similar nature. Leave alone the RCT, nothing comes there. RCT or this, that. What you experience in a similar patient, the same thing you have been. Okay, now, whenever the moment we open up the coronary artery, our routine has been to give some kind of intracoronary drug, either SNP or adenosine, before even proceeding for subsequent balloon dilatation or stenting. That pre-ballooning or pre-stenting, or after a small ballooning, going for the further ballooning, that preparing the bed with vasodilators really helps, rather than only directing all our therapies afterwards stenting. That is point number one. Point number two, once there is no reflow, however forcefully you inject through the coronary catheter, it doesn't reach the bed where it needs. So we very commonly practice using a perforated balloon, take it into the mid or distal area where there is no reflow, inject it through the catheter, rather than using one can use a micro catheter or things like that, but the easier one is to take a Oxford 2 millimeter. Yes, whenever there is no reflow with hypotension, there is no drug that helps other than adrenaline. The same technique, we take the perforated catheter into the coronaries, give adrenaline. It also helps the slow flow. It also helps the other myocardium to contract vigorously and pick up the blood pressure. And the dual way it helps. None of the other drugs is going to help. Neither SNP or adenosine, nothing is going to help. So no reflow, severe hypotension, intracoronary adrenaline is our choice. No reflow, the patient is very stable, intracoronary adenosine and SNP are our general drug of choice. This is my comment from my side, and that was a very nice presentation. Now it's open for discussion from my co-chair and other panelists, please.
And then our practice is, if we feel after judging what is the chance of no reflow, if we feel the no reflow chance is quite high, we always aspirate and use the aspiration catheter to infuse the drugs. Our major use is nitroglycerin. My personal use is more nitroglycerin, sodium nitroprusside, adenosine. And I was using 1000 micrograms of adenosine. Everybody was telling, you are using a huge dose of adenosine. Now, when I went into the adenosine dosage, I found that 1 milligram is a small dose. You must give at least 2 milligram intracoronary. And better dose will be a 4 milligram. So we have to give pretty high dose of adenosine. And the nitrocandyl also 6 milligram, minimum of 6 milligram is the dose which was found to be useful in the studies. So the dose we are giving may be a small dose. We have to give really good dose of this drug.
Thank you, sir. Thank you, Dr. Jabir. Dr. Lijo Verghese, what would you do in your practice? Do you?
Right. Yeah, so like Dr. Kannan suggested, we used to have something called a clearway catheter, which I think currently is not available. We were part of a randomized trial using the catheter. The concept was good, but again, it didn't translate into clinical benefit. I think the study did not have a mortality or any sort of benefit to suggest any particular benefit from this particular catheter. At the same time, I do have a question to Dr. Jabir. See, the problem is we say excess thrombus burden, and we say giving better, intracoronary tirofiban or an infusion. But isn't that an antiplatelet, right? So, what has your experience been with intracoronary thrombolysis? I mean, how often do you need to use it?
I have only very small experience with the use of intracoronary thrombolysis. My friend Dr. Jagopal as well as Dr. Karthik, I think there is Karthik's paper also on it, and Dr. Jagopal's paper which was published in the Indian Heart Journal. They have pretty good experience in the use of intracoronary thrombolysis using streptokinase as well as connector plates. Now I feel, after going through the data, I feel that this is likely to be useful, but I'm yet to start the use of liberal use of intracoronary thrombolytic therapy. My experience is quite limited.
Dr. Manoj, Dr. Suresh, would you use intracoronary?
Yeah, I saw this. See, the intracoronary thrombolysis is large apical coronary arteries, then small microvasculature obstruction and no reflow phenomenon. I don't think it will get opened with intracoronary connective plates. Now, another thing is, all these drugs has to be administered very, very distally using the microcatheter. Giving these agents through a guiding catheter, I think it will not work.
Yeah, absolutely. I think we have large experience with intracoronary thrombolysis. What we do is we take the clot aspiration catheter, go deep inside, and we use urokinase. We have used TPA earlier. Now we are using urokinase because urokinase is much economical, and also it works very well. And you start depositing about up to 5 lakhs. We are given 3 to 5 lakhs depending upon the clot burden. You go deep down, start infusing the urokinase and gradually pull the catheter. The entire length of the vessel you need to deposit the urokinase, and you wait for about 10-15 minutes. Sometimes it clears, then you can go ahead. Otherwise, you bring back the patient 24 to 48 hours later, and it just works wonders. You can just later on you can do the stenting, and we also keep the pressures very high. Sometimes we even put the intraday balloon pump and noradrenaline support. The pressure head is very important. Then you do the intracoronary thrombolysis and defer the stenting. And this paper we've got about 108 patients. We have sent it for publication to CCI. I think it may get published. We are waiting for their response.
Dr. Manoj, do you give thrombolysis? Sir,
Noted.
Sorry. Somebody else bringing in points?
Okay, Ramdas here. So, Javed, one of the things which you said that verapamil is not available. The one which you can think of is giving diltiazem 1 milligram. It helps a lot, especially when you give diltiazem. There is always a chance of having a bradycardia as verapamil. So, what my advocation is, just give 1.2 milligram of epropin just before giving 1 milligram of diltiazem, and give an autoperfusion. I have never heard anybody speaking on autoperfusion. This particular thing I have been doing since last 20 years, which I have been told to do by my seniors, and it has been proved very well, excellent, especially in patients who have no great hemodynamics. So when the pressures are about 100, we cannot give all this so-called SNP, nitroglycerin or diltiazem. Your autoperfusion along with adrenaline is an excellent way in which we can get a better reperfusion. And what Jabir said is exactly right, that we generally give through the aspiration catheter deep inside after having a thrombocytosis. So that is one. And second part is thrombolysis. coronaries, when we know that this particular thrombus load is high, it is wise to give an intracoronary thrombolysis half the dose and rest half the dose intravenous. And maybe after 3 days, you can take them back again and see what exactly is happening, rather than doing any sort of things acutely there.
Ramdas, I just wanted to know about, how do you perform these auto perfusion?
30 ml you push, 10 ml each, that is 33 times, and then aspirate the entire blood out slowly, not fast, but push it very hard when you push back, and again infuse another 30 ml of saline. So it is just like giving autolysis when already you are in hypotension. Instead of giving the saline through the IV, you are pushing through the coronaries, 30 ml of saline, then aspirate 10 ml of blood very slowly and push back the blood into it. And again take the 30 ml of saline, push it back.
Alright, it is just
so this
like,
one way it has been proved beyond some.
It is like a fluid challenge that we do in the shock situation.
Absolutely, absolutely. And it has given absolutely great results without any ill effects.
I think one last comment, Dr. Sapu.
Can I add one? Yes. See, auto perfusion is very good, but please use a lever lock syringe over there. Don't use an ordinary syringe, because while doing this, aspirating from the coronaries, there is every chance that you can put in a little bit of this bubble of air, and it works wonders. Auto perfusion is something which works wonders. Professor A.B. Mehta used to always teach us to do auto perfusion always when we were DM candidates under him.
Dr. Deepak?
Yeah, ma'am. Ma'am, are we done with the session?
Yes, yes. So I think we can go to the next session.
Yeah, ma'am. Ma'am, there is a small challenge. They're not able to get the proper connection with us from Maitra Hospital. So I thought that it would be appropriate for us to just discuss on 3 cases. All the 3 patients were in cardiogenic shock. All the 3 patients had an acute left main occlusion, presented with cardiogenic shock or cardiac arrest in the casualty. They were managed in almost similar way, but all the 3 patients had different outcomes. So I thought we have another half an hour to go. I thought I'll share with you these 3 cases, and probably 10 minutes we can have some good discussion on because all these cases sums up something whatever we have discussed right from the beginning regarding what Dr. Manoj has mentioned. When you have a left main occlusion cardiogenic shock, he said that always feed the body and save the heart secondly. So in all the 3 cases we had different challenges. I'll take you through that. The first case is a 41-year-old gentleman. He was a diabetic. He presented to a nearby hospital with chest pain and hypotension. He had cardiac arrest, resuscitated, ventilated, and he was referred to us. It's 20 minutes drive from that hospital. He had multiple episodes of cardiac arrest and CPR done almost 20 minutes in the ambulance. He reached the hospital in the ER. He again continued to have cardiac massage another 20 minutes, so 40 minutes gone. Now rhythm, once in a while it regains, and however again he develops cardiac arrest. So this was the ECG taken when he was in the other hospital. Arrhythmias and an ST elevation myocardial infarction seen. Now what should be the next strategy like? Should we plan for a primary? We know that it's an ST elevation MI. Should we take him up straight away to the cath lab and open up the coronaries, or should we implant an ECMO, a mechanical circulatory device, and then go ahead with a revascularization procedure? What should be the thought? Because it's an unusual situation. Most of these left main occlusion patients, they do not reach the hospital. When they reach the hospital, we get these sort of patients once in a year or so. So all the 3 cases, one was done in 2017, the second one 2018, third one 2020. So what would be the thought of the panelist regarding this particular patient? Almost 40 minutes of CPR, heart is not contracting, echo is, rhythm is not there. So what would you do next? Revascularization or a mechanical support device?
I think this patient has to be taken to cath lab immediately, and somebody should start doing angiogram from the groin. The other person can work for the other groin and try to put an IABP. Sometimes in such acute occlusions like this, just putting a wire itself may open up the things, may improve the patient's condition. So don't waste time by putting a mechanical circulatory support. Just take him to cath lab and do an angiogram. And your assistant and your associate can start working from the other side and put an IUD.
So is there a difference of
if
opinion?
you've got an ECMO,
Yeah,
if you've got an ECMO,
same thing I
just-
opined earlier also. In acute MI situation, I do not give importance to other things like IABP or other things. The most important thing is opening up the vessel. The earlier you open, the better is going to be the outcome. So as sometimes mere passing out, and just we have to know the anatomy first, then mere passing a wire stabilizes the patient many times.
Deepak, it's a wonderful case that you're describing, and I would beg to differ with some of the comments made. Because the given situation that your patients described of 41 years who suffered multiple cardiac arrest and blood pressure is unrecordable, I think the hemodynamic stabilization takes paramount importance. And then once you have the hemodynamics introduced, I don't think it takes more than 6 to 10 minutes to introduce a VA ECMO. And once that is done, then you can certainly take a coronary angiography, because when the blood pressure is unrecordable, and if you do an angiogram, you may not necessarily be more wise, because the circulation and the blood pressure may not really improve, and particularly because you had multiple inotropes and vasopressors on board. I would also go by the lactate levels. If lactate is more than 3 or 4, I think it gives a much more significance for introducing the MCS upfront.
ABG lactate was 10. Karthik?
Yes, I think absolutely I agree with Manoj. If you got ECMO, you just go in and put an ECMO. Putting in support device later, it doesn't work. You have to have some form of support. With so much of CPR going, hemodynamics bad, you need support. We had a left main equivalent similar to it, left main LAD occluded, circumflex occluded, and I opened up within 5-10 minutes. I opened up, put an IABP. Later on, he never improved. I had to switch over to ECMO. It was too late. I think you should go ahead with if it's available. I mean, ECMO is not available in all the institutes. If you have one readily available, I think you should. Such a case, I think I would put an ECMO, then go and do the angioplasty.
So in our hospital, this particular patient got admitted early in the morning at around 10 o'clock. We were all available in the hospital, so we thought that we'll straight away wheel him to the cath lab with CPR, puncture both the groins, both artery veins and all. Then few of us would work on ECMO and others would go ahead with a angio and revascularization. That was what was done for him. Right coronary was reasonably normal, flow was preserved. The left main was totally occluded. We wired the left main, and then you could see that there is no flow inside the left main. We tried to do a thrombosuction, and following thrombosuction you could see that the flow is TIMI2, the microvasculature is not seen at all, and there is a critical left main bifurcation disease. We also tried to aspirate the circumflex. The catheter wouldn't go into the circumflex. Then the flow was better. Again, it was only TIMI2 flow, but all the vessels were it was opened up because the BP was too low. The flow in all the vessels were not seen at all. So we were continuing to work on the other groin, on the left groin for the arterial VA ECMO, and the right groin for the venous cannula. So we felt that there was critical stenosis at the circumflex ostium. So we thought that we'll do a gentle dilatation before we implant a stent from the left main into LAD. We didn't want to do a complex stenting, just a stent implantation from the left main into the left angio-descending artery. That was planned and that was executed. We also had a wire inside the circumflex artery. The stenting was done. We thought that we should avoid aggressive post-dilatation because the flow already was too bad in all the vessels. Now, in these views, you could see that the circumflex ostium was very critically diseased. In the first cranial view, you could see that the circumflex ostium is very critically diseased. Even though there was TIMI3 flow, we thought that if this patient survives, he would survive with an ejection fraction of 5% or 10%. We wouldn't be in a situation to take him up back for another procedure for the circumflex ostium with an very low ejection fraction. So we thought that whatever best possible to be done has to be done immediately. Our plan was just to dilate the circumflex ostium. We dilated with 2 balloons. Still, it was not acceptable for us. We did a soft post dilatation. Pot was done, and finally, because the circumflex ostium was not looking good, we had to go ahead with the tap stenting of the circumflex also. Now, at the end of the day, what we could achieve was TIMI2 flow in the vessel. By the time the ECMO also was cannula was implanted, here you could see here that in the first image you could see here that okay, the flow from whatever we are injecting into the left main, you could see that it's partly coming back into the aorta. It's going till the ascending aorta. If you look at the descending aorta, you could see that it's all coming back. You know that the ECMO flow is from the descending aorta upwards. So whatever blood gets ejected from the left ventricle into the aorta, it goes little bit forward and it comes back. So it means that when you have this sort of situations, you know that the LV is hardly contracting at all. The watershed point should be well in the descending thoracic aorta. Now here you could see that the watershed point, the area where the antegrade flow and the retrograde flow in the aorta meets, that particular point, if it's too close, the LV is hardly contracting. So that's what we could ultimately make out. So here you could see here, this was the final flow that we could achieve. It is hardly TIMI 2 flow. And in the second image, you could see that the root of aorta, the flow is not really going above from the root of aorta into the ascending aorta. So that's the ECMO cannula being implanted. That's the 25 French cannula in the femoral vein and 21 cannula in the arterial site. Now that's just regarding the watershed zone. You could see here that clearly that the watershed zone is well at the top of the descending aorta, making us understand that the LV is hardly contracting. So we implanted that because the LV was not contracting at all. You could again see here in the first image that in the aortic root, the contrast is staying there at all. It's not moving forward. So we thought that we would try to reduce the afterload by putting in a intra-aortic balloon also. So we, through the right groin, we implanted an intra-aortic balloon pump, and he was then connected to the ECMO. He was shifted to the ICU, those with the flows 82/70, the pulse pressure was not there because LV was hardly contracting, the pulsatility was not there, only the ECMO flow was there. Next day, this was the LV, like you could see that there is so much of edema in the left ventricle and it's hardly contracting. However, with perseverance, day 4, he was out of ventilator. However, again, he had a lot of challenges. He had hemolysis, he had hemoglobinuria, renal failure requiring continuous renal replacement. However, at the end of 8 days, the LV contractility improved, the blood pressure improved, and we could wean him off the ECMO, and that was the LV function as he was shifted out of the ICU. And later on, day 30, he was in the hospital for almost 1 month. He developed other challenges, complications, fever, sepsis, ARDS, and he succumbed to the illness. Now, before I go to the second case, again a similar case, can we have some difference of, does somebody have a difference of opinion regarding how to manage this particular patient?
Deepak, how did you vent the LV? Because see, the ECMO increases the afterload, and either you put an IABP or LV vent. So did you vent the LV?
Yeah, the options to improve the LV output would be, one, to have an IABP, so that during the deflation of the balloon you have a forward ejection little bit. So that's the minimalistic way of doing that. We try to do that. We put an intra-aortic balloon pump. Secondly, the second option would be to put in an impella. Impella was not available in 2017. And third option would be to have a septostomy, intra-aortal septostomy done. We were not at that point of time, a septostomy was not possible for us. But recently, when we had a patient with myocarditis, when we wanted to vent the LV, we had to, the surgeons took her up to the theater and they, through the pulmonary vein, they put in a cannula into the left atrium and vented the left atrium and left ventricle. So that was an option. We didn't have impella at that point of time, so we just settled with a intra-aortic balloon pump.
Yeah, I think that's okay. If you've got intra-aortic balloon pump, that will vent, but not to great extent like impella or a LV to aorta conduit. But some form of venting is required, especially when the LV is so sick, the afterload goes up and you need to vent. That's the only thing I want to ask.
Does somebody have
a fantastic case in 2007? In 2017, you could do these things. What else can be done at that point of time? This is a maximum you could offer, and maximum things were offered. What else? A patient who came in the cardiogenic shock with the left main occlusion. There was discussion before this also. Is it the flow that is important, or the hemodynamic support that is, the mechanical cardiac support that is important? I think both are important. So if we have two teams, these type of situations, it can be managed by two teams. One working on the mechanical cardiac support, one working to re-establish the flow. If the mechanical cardiac support installation takes a long time, by that time the myocardium will be totally damaged, and as Deepak said, this patient may survive with a 5% ejection fraction, and in the long run it may not be of much benefit. Did the patient survive, Deepak?
No. We lost him at the end of 30 days. Again, if you look at the data, the whatever Atolma registry, patients who undergo CPR for more than 20 minutes before all these mechanical circulatory devices are implanted, the outcomes would be only less than 20%. Survival would be only less than 20%. Out of that, 50% of them, they would need some destination therapy. Then only they are going to survive. But then it's challenging in our situation.
Deepak, one more thing, what we observe is the moment you open the artery, the pressure crashes. You need to have some form of circulatory support before you start opening the artery. What I would do is put in IVP and start doing the procedure so that the other team starts working on the ECMO. And these things should go simultaneously, and that's the only way you can achieve a good flow. What we have seen is without an IVP, you just go there and you see such a type of lesion, you put in a wire, the pressure crashes.
Karthik,
And
it's
if you
not
don't have
possible.
any support, then it will be very difficult without a support. I think we should have a support, some support, and then start doing it.
Karthik, it's
Yes,
not
Karthik,
possible
that is,
to.
on one groin.
True, very true. As Jabir has pointed out, one
groin
groin.
team will work on one groin.
If you're working
put
on
an
one
IVP
groin, you have an IABP in the other groin. Where would you put in the ECMO arterial cannula? So what we do is we work with one groin, put the arterial cannula in the other groin, and then come back and put in the intra-aortic balloon pump once we remove the catheter, coronary catheter.
Once removed out.
Now, has somebody got experience regarding venting the left ventricle with an intra-atrial septostomy? What is the experience like? Because that seems to be the major challenge when an ECMO is implanted. The afterload is significantly increased, and the LV contractility, you would expect it to be. The philosophy itself, it doesn't look acceptable for us.
Yeah, ideally it would be an impella or surgically they have to do a LV to aortic shunt. Those are the best ways you can vent, but IABP is the cheaper option. Better, I mean, it's not a very good option, but definitely it will, to some extent it works.
It's a painful thing, isn't it, Deepak? The patient survives for 30 days and then we are losing the patient. But you have to treat, if we treat 10 patients like this, we may save 2 patients. But we are saving 2 lives.
Very true. Our data, that's what our data says. The next case, I'll make it very fast. It's almost a similar thing that we lost the second patient also because of some other complication. Again, a 70-year-old gentleman, cardiogenic shock, left main occlusion, multiple cardiac arrest. We aspirated it. Once we aspirated the occlusion, we could achieve TIMI 2 antegrade flow. The BP was quite on the lower side, and that was the flow after aspiration. You could see that it's almost TIMI 3, but then there is no microvascular perfusion. So we implanted a stent, that's a 4 mm stent from the left main to LED. We were not very aggressive this time doing bifurcations and all. So that was the flow there. You could see that at the end of the procedure the flow is hardly 2. It's not more than TIMI 2. So we thought that we'll have an intra-aortic balloon pump first because the BP was holding on at around 60 systolic. This just the systolic BP was hardly 60, and you could see on the second image the heart is hardly contracting. We first removed the catheter from the right groin and implanted intra-aortic balloon pump. Once the intra-aortic balloon pump was implanted, he developed cardiac arrest also. Again cardiac arrest, CPR. So we decided that we'll have an ECMO implanted. So the ECMO was implanted last in this particular situation. The first one, it was simultaneously implanted. So here that's the ECMO cannula going in, and that's the cannula. So again continue to do CPR, and once we implanted the intra-aortic balloon pump and ECMO, we thought that we should have a look at the coronary because there was prolonged CPR after the procedure. Also we thought that the left main would have again got occluded. So that was the flow. Through the radial we went and checked the flow. The flow was good. And that's the ECMO as well as the intra-aortic balloon pump. The pressures continue to be low. You could see that it's 65/53, but then there was some pulsatility for this particular patient. But here for this particular patient, what challenge happened was day 2 onwards he started developing low platelet count. It dropped to 20,000, 10,000. We gave single donor platelet. All whatever possible was done. Whatever was possible, it was done for him. Ultimately, he started bleeding. Because of bleeding and all, ultimately we thought that we should wean him off ECMO, and he succumbed to that particular situation. Now, regarding this, any suggestions regarding the timing of ECMO?
Seeing this, Deepak, seeing these things reminds me the painful days of patients putting the patients on ECMO. And to be honest, I'm yet to save a coronary patient with ECMO support. A couple of patients we put on ECMO. The problem is perhaps we might have delayed the decision of putting the ECMO. By that time, he might have developed a myocardial damage. Just like in your case, they stayed with us for 2 weeks or so and finally succumbed. It's really, really painful, and it's a big headache for the interventional cardiologist. But he could save 2 lives. This is the only way we can progress.
Yeah, even our outcomes are very bad. We had 10 cases of acute myocardial infarction with cardiogenic shock on ECMO. We lost 8 of them. But what I had in my mind was almost always we put in ECMO as a eCPR in many situations. So the patients are extremely sick compared to Western data. Our patients are very sick, so probably that was the reason why I thought the outcomes are going to be extremely bad in these subset of patients.
Absolutely, Deepak. These are all sick patients, and especially platelet is one big challenge.
Yeah.
If it comes down SDPs, it just gets consumed. Even one SDP you give, it goes about 10-20,000, and it's not easy. You are left with no choice. You need to pull out the devices.
Yes, Karthik. And the third
Manoj
one is
here. I just wanted to ask Manoj, because he is a person among these. I think I could find only him who has used Impella. I don't know whether Karthik has used Impella. Have you used any Impella in acute MI, Manoj?
Well, I think the case that I showed you during your session about a couple of days back, and that was a patient with NSTEMI, but not an acute anterior wall MI. I think since we have a program now going on, we should be able to use it in any STEMI patients with cardiogenic shock. But I deeply appreciate the efforts by Dr. Deepak Davidson that even prior to 2018, when we didn't get the Impella available, doing an VA ECMO is the single important considerations for the MCS. And I've also had many cases post-CABT and STEMI with recurrent ventricular arrhythmias and protracted arrhythmias in cardiogenic shock requiring revascularization. I think it's important that we stabilize the hemodynamics much prior to intervening the cardiac or coronary interventions, because many times the low flow and slow flow is contributed by low systemic pressures. And most of the cases that Deepak had shown, and only TIMI2 flow, and that is not an appropriate physiological target for us to revascularize. So it all depends on the mean arterial pressure. So you have a mean arterial pressure about 60 and 65. I think the no flow, slow flow will be significantly less, and not much can be achievable by not having an MCS support. Also, I would say that it's better to do upfront. If we consider MCS support in our mind, it's better to do it upfront rather than during or immediate post-procedure or completion of the procedure, because there is a significant difference in improving the systemic perfusion, reducing the lactate, myocardial edema, and all those things matter. But if you have a stable rhythm with the hypotensive and myocardial stunning, and there is a sinus rhythm or atrial fibrillation, I think Impella is equally important, but it all depends on the availability at the place that you work. And that's why these technologies have been brought in. And it's good that we consider these technologies in appropriate cases. And we discuss that the outcome may not be really a promising outcome in most of these challenging scenarios with clinical presentation of cardiogenic shock. Even in best of the centers with cardiogenic shock, the survival is not improved beyond 50%. So in our cases, it may be much less despite the use of these important and expensive devices and having a large bore catheters in the groin. So these things have to be discussed upfront with the family. And if they are agreeable, I think there should be no hesitancy in applying these appropriate therapies.
Yes, sir. So regarding the third case, This was a very fortunate patient. He was 67, the youngest of the lot, and again presented with cardiogenic shock. You could see ST elevation in AVR and V1. Taken to the lab, the right coronary was reasonably okay, but then the thrombus burden in the left main was too huge compared to the other two patients. You could see that there is significant amount of thrombus there. The greatest advantage for this particular patient was the other two patients, they had recurrent cardiac arrest requiring prolonged CPR. This particular patient also had multiple episodes of VT-VF, but then all CPR used to be very short. Within short duration, he used to regain sinus rhythm. So he didn't have prolonged asystole. That was the greatest advantage this particular patient had. You could again see that the left main is occluded. We went ahead, wired LED, did thrombosuction. We removed lot of clots in this particular patient, and following that, we could achieve TIMI-3 flow. TIMI-2 flow at least. You could see here that all the vessels are diseased. The circumflex, ramus, diagonal left antidescending artery, all the vessels were diseased, but then we didn't want to achieve a perfect result. We didn't want to do a crossover stenting. We just wanted to, in the second image you could see that there is a critical stenosis in the shaft of the left main. So we decided that we'll do minimalistic work. We just took a 4 mm stent implanted at 16 atmospheres in the left main. That's what we tried to do. That's just at the left main before, positioned in such a way that it doesn't go beyond the bifurcation. So that was stenting was done, and then following that you could see that the flow was again TIMI-2. It didn't deteriorate. We took an catheter inside the aspiration catheter was kept inside the LED, and we gave a lot of intracoronary adrenaline because we were scared to give nitroprusside. A lot of intracoronary adrenaline also was given, and that was the final flow in both the vessels, LED as well as the circumflex. The flow looks reasonably better compared to what it was in both the other patients. Again, the microvasculature was bad. At this point of time, the blood pressure was pretty low. The BP was hardly 60 systolic, 50 systolic. So we waited in the cath lab. It wouldn't improve. Once the procedure was over, we implanted an intratic balloon pump. But beyond that, things were worsening. He develops now and then. He develops cardiac arrest, we were able to resuscitate. So we thought that with such a low blood pressure, probably you need to feed the body. We thought that we need to put in a mechanical support. So that was the reason why we went ahead with an ECMO. Here the challenge that we faced here was we were not able to puncture the left arterial groin. He had some problem with the iliac system. We were not able to puncture that. So we were in a fix what to do. We thought that we'll go through the at that point of time we decided that we'll go through the axillary artery. So we wanted to puncture the axillary artery. Moreover, unlike the other two patients, this particular patient was not in persistent cardiac arrest. There was some cardiac contractility. So we thought that we just need to support him. So both the other patient, our arterial cannula was 21 size. Here we thought that we'll downsize it and have the impella from the, we'll have the arterial cannula from the subclavian, from the axillary artery. So again, puncturing that was difficult. We had a wire positioned inside the subclavian artery. Then with the help of that landmark, we were able to puncture that, and that was a wire going into the axillary artery, and finally we were able to do further dilatations with bigger cannulas, and we implanted a 16 sheath. So you could see here that the 16 sheath is positioned inside the axillary artery, and it's coming into the brachiocephalic artery, and that was where we stopped. So we did minimalistic work in this particular patient, implanted an ECMO, aortic intratic balloon pump. Next day you could see that the LV has got so much of edema, it was hardly contracting. However, on day 4 the LV improved, the edema has become better, the blood pressure improved. The second image shows that the LV is much better, the edema is better. So he's survived, and we were able to send him home safe. But then we had told him that all the other vessels are significantly diseased, you should come back for a coronary artery bypass surgery. Because the LV improved this much, we thought that we should bring him back. We told him that we'll have the procedure at the end of 6 months. However, he came back for a procedure, angiography, repeat angiography after 6 months. That was the angiogram. All the vessels are deceased, but the LV was better at that point of time. So he underwent a bypass surgery. Now it's almost 6 months following bypass surgery. He's doing reasonably well. So this is a very fortunate patient compared to both the other patients. Probably because he was younger, he didn't have a prolonged CPR. So I thought probably that was the reason why he survived. And another reason is probably we did minimalistic work rather than trying to open up all the critical lesions. Thank you so much.
Yeah, thank you, Dr. Deepak. But if you notice, The right coronary injection showed a significant collaterals to the LAV. These are the patients who are relatively doing well. It all comes back to how much of muscle has been preserved before we start the procedure. So when you showed the last case when the right
Yes,
coronary
sir.
injection was taken, the entire LAV was filling, though it was filling a bit very faint, but that was enough for the muscle to keep alive. So that when subsequent supports came up, it improved. So really excellent cases. Personally speaking, we don't have any ECMO experience at all in our center. We have done only for 2 patients. They are also non-coronary patients. So I am kind of really watching and learning how kind of we should arrange ECMO and other things, and it was really encouraging to see all your very tough cases managed to the highly possible way. Thank you very much.
Look, all the three were very challenging cases. All your 10 cases, I wish the coming next 10, what you're doing, all the 10 survive. That is what I will say. It will be more encouraging for all of us, even now it is encouraging. The only thing which I want to tell is I am very happy to know that you could convince all the 10 people to put an ECMO, because to put an ECMO is not a small amount. And when you say that the patient is not going to survive, if somebody is going to willing to shell out another 5 lakh on an ECMO, I don't know how much it costs in your institution. It's really challenging to convince the patient relatives that to put in shelling so much of money, and that is for ECMO, and then long term of stay. So that is one thing which we'll all have to look into, work on that, and if we can do something with it, definitely I think we all can help out many of them. Otherwise, it was a very great cases, Deepak. As usual, all his cases are very challenging. And a great meeting too, Deepak.
Deepak, there can't be a much better way to conclude this 3 days of Conquer the Coronaries. You made it that day by presenting these 3 wonderful cases of cardiogenic shock, and the role of MCS is much more amplified through your illustrated cases. The last case which you demonstrated, my simple suggestion for you would be, since you went through the axillary, the ultrasound guided puncture is what is being preferred worldwide now, because the fluoroscopically you might enter into the axillary vein and sometimes even cause more hematoma there, because most of these patients are heparinized. So ultrasound guided groin puncture is what is recommended, and whether for axillary also is ultrasound guided. So I think that makes it much simplified. Or you may get a surgeon to expose and then have the cannula inserted. So these are the ways of improving our own skills. We are all learning, and I think more and more we continue to do. We seem to be committed to the conviction that some patients would do survive with this ECPR.
And sir, just a point regarding the cut down. Sir, just a point regarding cut down. Initial cases, we always used to have the surgeon to cut down and put in the cannulas. But then what happens is all these patients do need dual antiplatelet therapy. We would invariably want to keep them on GP2B3 receptor blockers because the flow is not good. So at the end of the day, they'll keep bleeding from the groin arteriotomy and site. So what we do nowadays is we try to implant it percutaneously, and when we remove it, we open it and do it properly. The suturing is done properly.
Deepak, another way to do is use a micropuncture needle. We always use ultrasound guided and use a micropuncture needle. Even if you don't get it and if you pull out the needle, not much of bleeding happens. As Manoj rightly pointed, all these patients are heparinized. We have to be very, very sure. So it has to be ultrasound guided and using a micropuncture needle.
Yes.
And that will minimize your complications. Later on, you can change over to a bigger needle once you are in.
Ma'am, if there are, ma'am, you're muted.
Thank you, sir. Thank you for the cases. So we acquired an ECMO, so we'll always seek your help for the cases. So thank you for the meeting, and I think if it's okay with you, are we going to conclude?
Yeah, ma'am. We'll. It's in fact my pleasant privilege to propose vote of thanks also in this juncture, I would want to thank all the moderators, expert panelists, as well as the speakers who have joined over the last 3 days. Yeah, I would want to profusely, immensely thank them. I would also want to thank all the attendees. I would want to thank the audiovisual team from Coimbatore, Anand and team. I would want to thank everyone from all the office bearers of EAPCA as well as Rubber City Heart Foundation. Last but not the least, I have a big team of Abbott crew over here who made this event possible. I thank each and everyone. Thank you so much. Good night.